Okay. So as I was saying, we have received so much support and active participation from all. So today, as we start off with the final day 3 of this web series on Vertigo, I would like to introduce our special guest and speakers for the day. We have respected Padma Shri Dr. Mohan Kameshwaran Sir as the mentor faculty and keynote speaker. Then Dr. Srinivas Dorasala Sir as the chief faculty, Dr. Gautam Khan Sir as the convener, Dr. Surajit Burman Sir as the chief coordinator and the speaker for today's session. And our other esteemed speakers include Dr. Julfikar Hazarika, Dr. Vijay Vishwanath Ghuge, Dr. Henry Nongram, and Dr. Jagtap Charuzaz. I would now hand over to Dr. Gautam Khan Sir to make his opening remarks.
Thank you, Sanchita. Good evening, ladies and gentlemen. At the outset, I'd like to thank all the viewers on our LiveMed website as well as on the YouTube channel for being so supportive of us and connecting with this meeting, this web series on all these 3 days. I would like to actually thank Professor Mohan Kameshwaran Sir. Everyone knows how busy he is. He agreed immediately to be with us on the 3rd day today on the web series. We are also thankful to the other mentor faculties that we had on the day 1, Dr. Anirban Biswas and Dr. Kirtane Sir on day 2 as well. Srinivas Dorasala is almost like a part of the family, though we are calling him the chief faculty. He is with us throughout. I would like to actually thank the members of our team, some of who are behind the scene, like Dr. Biswajit Gogoi, who's our main technical brain. And then there's Mr. Jayanta, who runs our website, who has been doing a good job. And Sanchita, as you don't see her face, she's always on the mask because she's in the hospital. And Vivek, Dr. Anjana, Dr. Devika, and of course Surajit is omnipresent. And I would also like to thank Abbott Neurolife for their partnering with us in this event. And last but not the least, we are thankful to Dr. K.K. Handa, the president, and Dr. Vijay Krishnan, Academy of Head and Neck Surgery, IOHNS, for collaborating with us in this event. And of course, today we are lucky that we have the founder president of IOHNS with us. So with these few words, I welcome everyone, all the speakers of today, Dr. Jagtap, Dr. Huge, to Dr. Zulfikar and Dr. Henry. I hope we'll have an entertaining time and learning experience. Thank you very much.
So our first talk is on functional dizziness, the mimics, by Dr. Julfikar Hazarika. May I take the pleasure to from Guwahati Medical College. He received training in Tata Memorial Hospital in head and neck surgery. He developed keen interest in neurotology and has been participating in several workshops, including the one in Shillong, where Dr. Srinivas Dorasara Sir was the resource person. He currently is working in Bethany Hospital, Shillong as a consultant ENT specialist. He is an avid cyclist and nature enthusiast. And let me also include that he, along with Dr. Henry and another doctor colleague, has been the proud owner of a sports cycle shop and has been popularizing the sport in Meghalaya. Yes, we welcome Dr. Julfikar Hazarika to start off the session.
Thank you so much for your kind words. Am I audible?
Yes, sir. Yes,
okay.
Sir.
Thank you so much for your kind words. At the outset, my deep appreciation to the GVSB group, that is Dr. Gautam Khan, Dr. Vivek, Dr. Surajit, Dr. Biswajit for number one, having this wonderful web series, and secondly, for allowing me to talk in this web series. Thank you so much. I will be talking on the mimics, that is functional dizziness. What are functional disorders? Vestibular disorders are divided into structural, functional, and psychiatric conditions. Functional conditions in this condition is considered as those which arise from a change in the mode of action of an organ, and it is unrelated to any structural or cellular deficit. So this concept of functional condition distinguishes them from psychiatric illnesses. So the most important part, what we have to know here is that functional disorders are not a synonym for any psychogenic or psychosomatic disorders. Functional dizziness, the most important is persistent postural perceptive dizziness, which is also called triple PD, and Malle-Berkman syndrome, which is a rare syndrome. So what is persistent postural perceptive dizziness? We will go back a little bit of history, because we had in the past 4 conditions which had overlapping symptoms, similar and overlapping symptoms of these 4 conditions. So these are phobic postural vertigo, which is also called PPV. This was described in 1986 by Brent and Dietrich. And it is a clinical syndrome of postural dizziness with fluctuating unsteadiness. And it is associated with mild anxiety and depression. And it is usually seen in patients with obsessive compulsive personality traits. The second disorder, called space motion discomfort, was described by Jacob and colleagues in 1989. And it is a combination of uneasiness about open spaces and spatial orientation, and increased awareness of the patient's or the person's self-motion. The third condition, called visual vertigo or VV, was described by Bronstein in 1985. This syndrome was identified in patients who had acute peripheral or a central vestibular loss, like vestibular neuritis or vestibular migraine. And it again manifested with sensation of unsteadiness and dizziness after he becomes okay of the preceding disease. And then chronic subjective dizziness was described in 2004 by Stab and colleagues. It is very similar to PPV, but it focused primarily on the physical and not the psychological symptoms. So what happened is, because of this overlapping symptoms, the Berani Society in 2010 formed a behavioral subcommittee to identify primary and secondary psychiatric disorders, which either cause or amplify vestibular morbidity. So in 2014, this disorder was named persistent postural perceptual dizziness. This is to reflect this name reflects the main diagnostic criteria of persistent non-vertiginous dizziness. Patient does not have a spinning sensation. He has dizziness, he has unsteadiness, and he has non-spinning vertigo. These are increased by postural challenges like standing and walking, and there is perceptual sensitivity to space and motion.
Zulfi, you can tap on your mouse, not on the key, then it will change.
Yeah. The incidence and prevalence of triple PD. Triple PD, what we talked before, is not a very rare condition. It is seen in about 25% of patients who undergo acute or episodic vestibular disorder, that is like vestibular neuritis, BPPV, vestibular migraine, or Meniere's disease. If these patients are followed up for about 3 to 12 months, then we see in 25% of these patients that they have triple PD. And this is seen despite otherwise adequate recovery from the initial illness. That is, the patient recovers from their illnesses, which may be vestibular neuritis or BPPV or vestibular migraine. But if we follow them up for 3 to 12 months, we see that they have developed the symptoms of triple PD. The prevalence is about 15 to 20% among all patients who present for evaluation of vestibular symptoms. It is found to be the most common diagnosis among young adults, and the second most common amongst all adults after only BPPV. The average duration a patient suffers this illness before he comes for a tertiary consultation to somebody who practices vertigo or autoneurologist is found to be 4.5 years. So what are the criteria for diagnosis of persistent postural perceptive dizziness? So triple PD is a chronic vestibular disorder, and it is defined by 5 criteria. And all these 5 criteria must be fulfilled to make the diagnosis of triple PD. Criteria A, the patient must have symptoms of dizziness, unsteadiness, or non-spinning vertigo on most days for more than 3 months or more. The second, the part of this is that the symptoms must be prolonged. It cannot be minutes or seconds. It must be prolonged. It should be hours long period of time, but it can increase or decrease in severity. And the symptoms need not be present continuously throughout the whole day. He might have a long duration, about 4 or 5 hours of symptoms, and then he might feel a little better. Again, the symptoms comes back. The symptoms must be present for more than 15 days of every 30 days. Criteria B, the symptoms can occur without any specific provocation, but these are seen more by 3 factors. That is upright posture. Triple PD is rarely seen in patients who are lying down. They do not have these symptoms. They are increased by active or passive motion. Active motion means when the patient is walking, and passive motion means when the patient is having a passive motion like riding a car or riding a train or a bus. And the third factor which increases the symptoms of triple PD are exposure to moving visual stimuli or complex visual patterns. So moving visual stimuli is when the patient sees a large body of traffic or a gathering of many people. Or complex visual patterns means when he sees patterned carpets or striped curtains. This is an example of moving visual stimuli is when a patient of triple PD walks down an aisle of a supermarket, he'll feel giddy, he'll feel the symptoms of unsteadiness and non-spinning vertigo. This is an example of complex patterns. Criteria C for diagnosis is the disorder is precipitated. That is, it is started by conditions that cause vertigo, which can include acute, episodic, or chronic vestibular syndromes. So the most common of these are vestibular neuritis, BPPV, or vestibular migraine. So when the precipitant or when the cause which causes triple PD is an acute or episodic condition, then the symptoms settle into the pattern of criteria A, meaning the patients will start having symptoms of giddiness when they are upright, when they are moving about, when they see traffic. And then as the symptoms of the precipitating condition decrease, they will develop the symptoms of triple PD. They will continuously have this dizziness, unremitting dizziness. If the precipitant is a chronic syndrome, then the symptoms may develop slowly at first and worsen gradually. I mean, they will slowly become worse. This is criteria C. Criteria D for diagnosis is the symptoms must cause significant distress or functional impairment. The patient will come and tell us he's unable to work, he's unable to think, he's depressed. And criteria E for diagnosis is symptoms are not better accounted for any other disease or disorder. How do we make a diagnosis? We know the criteria for diagnosis. So how do we go about making a diagnosis of triple PD? The most important part of diagnosing triple PD is the clinical history, and especially relevant to criteria A and D. We must remember that there are no findings on physical examination or laboratory testing or imaging that are pathognomic of triple PD. So there are no specific laboratory tests, nor no specific physical examination, or no specific imaging which can diagnose triple PD. We must always remember that if the patient meets all the criteria of triple PD, and we find an abnormal finding on physical examination or a laboratory test, it does not mean that triple PD is not present in this patient. It can mean that there is an ongoing presence of a precipitating condition or another coexisting illness. Furthermore, the most important thing to remember is PPPD is not a diagnosis of exclusion. If we find a patient who does not fit into all our conventional diagnosis of vestibular disorders, we cannot put that patient into the diagnosis of triple PD because it is not a diagnosis of exclusion. What is a clinical course like in a patient of triple PD? In maximum number of patients, PPPD develops as acute symptoms. As the acute symptoms become better, then the symptoms of triple PD develop. Patients usually do not experience any symptom-free interval throughout their period of suffering. In the minority of cases, PPPD has an on and off course in which patients usually experience triple PD-like symptoms, which last for weeks to months, then become okay, and again starts until they settle into a persistent course over a period of time. Differential diagnosis of triple PD includes almost all the conditions that we know which causes dizziness. I will go through them briefly and try to, how to differentiate between triple PD and these conditions. So these are divided into 4 categories. Category 1 is chronic sequelae of any acute disorders. So the most common of these are vestibular neuritis and stroke, leading to persistent uncompensated vestibulopathies. So how do we differentiate? Number 1 is history, and number 2 is check for compensation status. If we find that a patient is well compensated, he does not have any spontaneous nystagmus, his Romberg's test is normal, then we can, it goes more towards, and it fits all those criteria of diagnosis A to E, then it goes more towards triple PD. But if we find that the patient is uncompensated, he still has nystagmus, then we have to find other diagnosis for this patient. Category B is recurrent attacks of episodic disorders. So the episodic disorders that we know commonly are vestibular migraine, Meniere's disease, and PPPV. So how do we differentiate between these 3 conditions? And triple PD is in migraine, we will have headache, we'll have photophobia, we'll have phonophobia. It might be with or without visual order. In BPPV, we will know that the patient will have short-lived positional vertigo. And in Meniere's, we will have the triad of vertigo, tinnitus, and fluctuating hearing loss. Category C is ongoing manifestation of chronic disorders. Chronic disorders like anxiety and depressive disorders, post-concussive syndromes, and autonomic disorders and heart diseases. So what happens in these conditions is that the patients are not greatly affected by standing up or walking or looking at visual stimuli, which is seen more in PPPD. The last differential diagnosis, the last group of differential diagnosis are other chronic vestibular syndromes like bilateral vestibulopathy and neurodegenerative disorders. Bilateral vestibulopathy, how do we differentiate between triple PD is we will get bilaterally positive head thrust test, we will have diminished response on head impulse testing and caloric irrigation. Neurodegenerative conditions like Parkinson's disease, how do we differentiate? Parkinson's disease or other neurodegenerative disorders will have a very gradual onset, which is not seen in triple PD. Triple PD, we will always get a history of, mostly get a history of an acute disorder, vestibular disorder, followed by continuous unrepeating dizziness, which is not seen in neurodegenerative disorders, which are more gradual and takes a long time to develop. Coming to treatment. So how do we treat triple PD? The most important part of triple PD starts in educating the patient about the disease. When the patient who has been, going from one doctor to another for, we found out that, the time to initial diagnosis is about 4.5 years. And once we can tell him that the patient has an identifiable disease, which is diagnosable and which is treatable, the patient will have a lot of relief of his anxiety, increase in trust in the doctor, and hopefully he will follow the treatment well. So number 1 treatment option is vestibular rehabilitation therapy, the most important part of which is habituation exercises. Habituation exercises are targeted at challenging the patient's balance, and exercise for triple PD must be started more gently and increase more slowly than we do for other vestibular disorders. Otherwise, it is usually seen that the patient do not take up these exercises because the sense of swaying and fall, the feeling that they might fall is very high. The basic aim of vestibular rehab therapy is to fatigue the abnormal reflexes responses, meaning that repetitive exercises are done which will remove this the abnormal reflexes which are seen to movement tasks like walking or standing or looking at complex visual stimuli. The other category of treatment is medication, that is selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors. These are seen to reduce dizziness and unsteadiness in a majority of patients. The doses that are used are usually half the doses that we give for depression. How a SSRI is usually used is, SSRI is given and a trial is given, and then particular SSRI is not working, then we can do a trial of another SSRI, a second SSRI. If we find that the second SSRI is also not working, then we can switch it to a serotonin norepinephrine reuptake inhibitor or a SNRI. If we find that any of this particular medication is effective, which is usually seen after stents, they always have the fear of falling. They have a lot of visual dependence because they don't trust the vestibular organs. So they are taught to recognize the abnormal stiffened posture and then think for themselves, this is not correct. Why am I doing this? So this helps with cognitive behavioral therapy, as well as what happens is any spontaneous physiological body movements like physiological body sway, which is normal in everybody. This is interpreted by a patient of PPPD to be a sense of falling down. So there is overreaction to a normal physiological body sway. So CBT takes care of this also. Coming to this rare syndrome of Malle-Bergman syndrome, it is a very uncommon vestibular disorder. It is characterized by a sensation of swaying or motion, usually after a patient disembarks from a vehicle such as a ship or a plane. However, it has been found to occur spontaneously as well. Interestingly, these symptoms temporarily subside when the patient again sits on a car or a moving vehicle. The patient feels better. Anxiety, depression, chronic fatigue are frequently seen with this syndrome, and it's seen more commonly in women. So how do we treat this? The usual clinical treatment for MDDS is to make the patient know that he has a treatable condition, to make the patient feel comfortable, and we wait for the MDDS to usually end by itself, which takes up to 6 months sometimes. Conventional vestibular suppressions are not useful and should not be prescribed in patients with MDDS. Clonazepam are usually helpful, can be given for a short duration, but we should always remember that they have addiction potential. SSRIs has recently been found to be helpful also in treatment of Malle-Bergman syndrome. Another therapy for Malle-Bergman syndrome is reported by Dye and Associates in 2014. What he said is, if you make the patient look at a full field visual stimulus like an optokinetic stimulus, and you rotate the head from left to right, then he has found that in 24 subjects, 17 were very successfully treated of Malle-Bergman syndrome. So coming in summary, functional dizziness are more common to be taught. They are, they form about 25% of any acute vestibular syndrome that we see. And if we follow them up for 3 to 12 months, we will find that quite a lot of them has triple PD. This might be severe in some, and some might be living with it, but this should be followed up and found out. We should always remember that they are not psychogenic or psychosomatic disorders. Although a lot of these people suffering from triple PD might have coexisting psychological disorders. Most important part of educating the patient about the disease, making them know that there is a diagnosis and there is treatment, which will go help in a long way in treating the disorders. Thank you so much.
Thank you, Jyotika sir, for your extensive elaboration and excellent deliberation. Moving ahead with the much-awaited keynote lecture on surgery in vertigo by Padma Shri Professor Dr. Mohan Kameshwaran sir, a much revered figure in the field of otorhinolaryngology. I feel extremely honored to read out his prolific biodata. Padma Shri Professor Dr. Mohan Kameshwaram Sir is the Senior Consultant and Managing Director of Madras ENT Research Foundation. Professor Kameshwaram Sir has been adorned with the prestigious Padma Shri Award in 2006 and Dr. B.C. Roy Award in 2008. A pioneering cochlear implant surgeon in India and South Asia, with personal series of nearly 4,000 cochlear implants, Professor Kameshwaram Sir has been the first ENT surgeon to do auditory brainstem implants in South and Southeast Asia and has a personal series of over 50 auditory brainstem implants. With several publications in major national and international journals and presentations in almost 450 national and international conferences, Sir has been an invited lecturer in several of them. Professor Kameshwaram Sir has conducted and attended over 325 workshops on temporal bone laser surgery and audiology for surgeons. He has been the recipient of Indo-Australian Award 2006 and National Award of Excellence Sri Lanka in 2007. He is the Doctor of Science honoris causa in the Tamil Nadu Dr. MGR Medical University. He is the visiting professor, Edge Hill University, UK. He is also the honorary professor in the Department of ENT in SRM Medical College, Hospital and Research Center in Chennai. He is the adjunct professor in the Tamil Nadu Dr. MGR Medical University, Chennai. Sir is the member executive council in National Academy of Medical Sciences, India, the member governing body of International Federation of Otolaryngological Societies, member of the executive council of Pulitzer Society. Sir is the past president of Asia Pacific Symposium on Cochlear Implants and Related Sciences. He is also the visiting professor of otology in the Royal Society of Medicine, London in 2015. Welcome, sir. I now would hand over to respected Professor Kameshwaram, sir, to initiate the keynote lecture on surgery in vertigo.
Thank you so much. Good evening to all. And first of all, let me tell you all how happy I am to be here today to share this evening with you all. And a special thanks, of course, to Gautam and all the organizers for asking me to be here. It's a huge honor, and I really am very grateful to you all for asking me to be here. Now, Gautam has asked me to talk to you all about surgery of vertigo. Now, before we go into that, I must tell you a little bit about the way this particular area has waxed and waned. Now, when I started my career in the 70s, surgery of vertigo was very much the cutting edge of the specialty. And in the 80s, when I was, had qualified and I was working in the UK, surgery of vertigo used to be on every list, every theater list that you could think about. And somewhere in the 80s, I became a professor in Middle East, Saudi Arabia. We started the first medical college there. And I can tell you that in 1 year alone, I had done about, just looking at my statistics, in 1 year I had done about 85 translabyrinthine vestibular sections. So it was a very common list, almost one list every other day, one surgery. And, if you include also surgeries of vestibular schwannomas and so on, practically every day you would be doing some surgery for vertigo. All that has come down now. And we are now at the stage where if we do one in a center like ours, if we do one in perhaps a fortnight or 1 or 2 cases a month, that will be quite an achievement. So, this is a huge change now from a sudden decline in numbers. Why is that? And in fact, the real reason I suspect is because we are now understanding pathology of vertigo far better than we did. And we also realized that the importance of giving time and the importance of things like vestibular exercises, rehabilitation, and the role that they have to play. So the amount of aggression that we surgeons had towards vertigo has come down. So having said that, uh, you know, there's no doubt that the surgery of vertigo is one of the most technically challenging surgeries, not only. Certainly, it is over the years, the development of the microscope and the endoscopic techniques and the refinements of the drill and so on, and also the better monitoring, occupation of monitors, so on, has certainly helped the safety profile of the surgery. It may be a very simple procedure, like placement of a ventilation tube or in a patient with diffusion, or it may be a very complex procedure like working on the vestibular nerve and so on. So it's a whole variety of surgeries that you can be talking about. In brief, you can sort of narrow down the indications to these four categories. It is vertigo, which is complicating chronic otitis media, and in Meniere's disease, which is resistant to medical management, in chronic position vertigo, and in CP ankle lesion. So more or less, you can come down to this four categories. What is the goal of surgery in vertigo? Basically, you want to abolish or alter the function of the disease pattern, or you want to modify the underlying pathophysiology so that it becomes less of an irritant for the patient. Then, what are the contraindications for surgery? One thing you definitely will not be doing is, you don't want to be doing this surgery on vertigo, only hearing ear. So today that would be a very, very important concern. Also, when there is an involvement of the central nervous system, which may be contributing also to the vertigo, surgery is obviously not the answer. Poor medical condition of the patient, because some of the surgical procedures can be quite a challenging, quite a challenge to the metabolism of the patient. And certainly, when there's bilateral disease, you don't want to be operating on the ear because of the risk of the Dandy syndrome or bilateral syndrome. And what are the anatomical targets of it? Which are the areas where anatomically we go and operate? You could be operating on the perilimb, you could be operating on the endolimb, you could be operating on the vestibular nerve. We could be dealing with vascular compression syndrome or extraaxial lesions in circular body and ankle like vestibular. These are all the anatomical targets that you might be looking at. Now let's start off with the perilimb. So whenever you have a chronic ear disease, and when there is an associated fistula, like a lateral canal fistula, then of course that would be a different indication. Severe episodic canal syndrome was something which is now recognized universally quite recently. And it is a definite, again, if it is significantly disturbing to the patient, it's definitely temporal bone trauma as well as non-traumatic perilimb fistula also constitute indications of surgery on the perilimb. So let's look at the first category. Now we can all see the CT. You can see there's an erosion of the lateral canal in the patient. And the surgery of the labyrinthine fistula is pretty straightforward. That is, you keep the fistula to the very end, the matrix of the fistula. The last bit you just now remove the fistula, the matrix. You can see the fistula there. That's the stapes head. And look at the fistula when you move the stapes head. You can see the third window blinking. Just like you get a round window reflex. So that tells you a couple of things. One, that the fistula is involving the penile space, and secondly, that the endosteum is still in there. Of course, immediately you line it up with the fascia. Uh, the fistula is almost always sealed with some maybe a bit of fascia or a little bit of muscle, and immediately after the matrix, so that you don't have a big lag in time. Superior semicircular syndrome is a very interesting condition where the patient complains with a whole myriad of very interesting symptoms. he could be, disabled by chronic unsteadiness. One problem that he will have. Truly a phenomenon where loud noises can induce vertigo, can be seen, just like you see in vertigo. And Henneberg sign, which is vertigo induced by pressure over the oscillopsia. That is, every time the patient is walking, the whole visual field is moving up and down, so that it looks like it's a very unpleasant sensation actually. And pulsatile tinnitus, some of them definitely complain about. Hearing loss is usually a conductive hearing loss. Autophony, that is, they can hear their own sounds, and especially when they're talking, they can hear their own voices in a very distinct way. And certain hypersensitivity to bone conducted sound. So they may complain about the fact that every time they're walking, they can hear their own footsteps going all the way to the ear, or some of them may give very peculiar symptoms, like I can hear my eyeball moving. Things that we think very often is functional, but it's actually quite true in these patients. And generally, the surgery is the answer for a patient who's very significant debilitating. And the surgery could be done either by the middle fossa approach or by the transmasted approach. In fact, my own preference is the middle fossa approach because it's a very simple procedure and it can be done very, very easily. But you can also go through the transmasted approach and then the resurfacing, either with some bone patchy or soft so this is a very simple procedure, very rewarding results. Sometimes, and I've seen two or three situations, there may be more than one fistula. For example, there may be a superior septicematosis along with the posterior septicematosis. So I've seen this now in two or three patients. Interestingly, one of the first patients I saw was an audiologist. Documented symptom very well. And in which case you have to resurface, of course, both the windows. So, not just a third window, there's actually a third and a fourth window, or 3A, 3B window. So you have to resurface. And it's quite effective. The symptoms are immediately abolished. Patient feels very, very reassured. Now, coming to the endolymphatic space, this is typically seen in veneers, in long-standing veneers disease, which is refractory to medical management. So, what is refractory to medical management? This is a very, very related term. Actually, it varies quite a bit from perspective. Generally speaking, the consensus is that you have at least given 1 year of good medical management, maximal medical therapy, which includes a diuretic like a thiazide diuretic, and give a similar rehabilitation and so on. And in spite of that, the patient is still disturbed sufficiently that they cannot lead a normal life and is not able to pursue the profession. And despite having good salt restriction, food restriction. So these are the patients who you're very frustrated. They are very frustrated because you have done everything possible. You give them all the advice, and yet the patient is symptomatic and comes with regular attacks of acute attacks of exacerbation of mania and hospitalization, and they are very disturbed. Now, these are the patients in home surgery you would consider. At least you're sure you have done your maximum. Now, the way this is managed, of course, there are various options. You could be ablating the offending lamina by chemical ablation, or you could be denervating the offending lamina, or even excentrating the offending lamina. So you have various options. So you can do a chemical ablation, maybe doing a vestibular nerve section, or you may be doing a laparoscopy. Now, the chemical ablation started off in 56, as early as 56, when Shuktak reported the use of intratympanic injection of streptomycin for treatment of Meniere's disease. It was quite an interesting concept because he actually showed the first time that you could actually put it in the middle ear and through the round window membrane, there's a possibility that the drug could go in high concentration. And the round window membrane itself is a very interesting structure. One thing we all have to know is that the round window is almost like your fingerprint. No two round windows are alike. And even in the same patient, sometimes between the right and the left side, you'll find a different subtle difference in the round window. So the round windows, various sizes, shapes, and the various. But one thing always is true, and that is the round window membrane is always perpendicular to the primary tympanic membrane. Secondary tympanic membrane or the round window membrane is always at right angles to the primary tympanic, and it has three layers through which the drug has to percolate. But the fibrous layer, just like the primary tympanic, the fibrous layer is very, very thin, and the whole thickness is just over 70 microns. Now, when you are giving intratympanic treatment with an ablative drug, now generally nowadays most people are, and the vertigo control is seen in a significant number, more than 75%. And some series say even up to 100%, but I think something like 75% is realistic. But there is a hearing loss seen in at least a third of these patients. The advantage, of course, is the drug is reaching high concentrations in the offending labyrinth, minimally invasive. It does not affect the opposite ear. So then the side effects, systemic side effects are completely avoided. The opposite ear is not affected. The renal damage also is not seen. So these are all some of the big advantages. Now, one of the drugs which has been used quite extensively is intratympanic steroids, particularly long-acting steroids like Amlodipine and so on, or of course, even short-acting steroids like dexamethasone, mainly intended as an anti-inflammatory agent with the concept that Meniere's disease is an inflammatory disease. It does, of course, steroids we know influence ion transport, and the preferred drug by most people is dexamethasone. But some people also add long-acting steroids like that. Vertigo control is seen in about 50 to 60%. A very big number, but it's a very minimally invasive procedure. So people say, why not try it? It works, it works. It doesn't work, nothing else. There are complications are really very, very few. Technically, you could have a hearing loss, although it's very, very rare. It's been documented, but it's very, very rare. And persistent perforation of the tympanic membrane, occasionally audit dyspnea, but systemic absorption is very, very rare. Gentamicin, as I said, is really the more preferred tympanic, and it works by destroying the hair cells and also the autochronia. It's particularly useful in unilateral Meniere's disease, not responding to maximum medication. And in patients in whom there is already a significant amount of hearing loss. Also in the elderly, can't be thinking about very major interventions and medically informed patients. There are various, protocols which have been worked out for using, and once a day, Beckett Schmidt was the first protocol, once a day for 4 to 6 doses, up to an average of about 6, sometimes even up to 10 or 12 doses. And CAS gave once a week for 4 weeks, and so on. Now, our own center, what we generally recommend is to be giving one dose a week to a maximum of 3 doses. And the vertigo control is quite gratifying, more than 80% of patients. That the hearing loss is seen in at least about a third of patients. It can also be, instead of injecting every time, some people prefer to put in a grommet and do the grommet, or there are others have tried micro wigs, like round window microcatheters. But a simple grommet would work quite well. You don't want to be injecting each time. It is never done bilaterally because of the risk of dandy syndrome. What about surgical procedures for Meniere's disease? Now, as I said, it's become very, very rare. Probably less than 10%. I would say even less, around 5% or less for Meniere's disease really end up needing surgery. So medical management is by and large quite successful in the vast majority of patients, particularly when they understand the disease and are quite willing to cooperate with you in terms of salt restriction. The factors which determine surgical procedure are the symptoms. there should be sufficiently disturbing whether the patient's normal life is the age of the patient. We don't want a patient, the elderly, usually after the age of 70, their compensations are really poor. These patients are also patients who have other medical maladies. So generally after the age of 70, of course there are exceptions, some very young, fit 70. So you really have to assess the patient. And the degree of hearing loss. So if the hearing loss is significant, then you think about a whole set of different procedures. If there is some significant residual hearing, then you think about other procedures. And also the status of the frontal lateral. The auditory status is the main criteria for selecting whether this patient is going for a conservative procedure or a destructive procedure. In other words, is the hearing worth preserving? Now, what is a hearing worth preserving? What is serviceable hearing? Of course, this is, undergone a radical change, but classically, we used to have what is known as a 50-50 rule. That is, hearing threshold is more than 50 decibels, and speech discrimination is less than 50%. If the 50% speech discrimination score is there, it's a hearing worth preserving. And if the hearing loss is also within 50 dB, definitely that hearing is worth preserving. Hearing loss is more than 50 dB and hearing speech discrimination is less than 50%. Such a hearing was thought to be not worth preserving. Of course, this concept has changed radically now. Today, we would say what is known as a 70-30 rule. This is the rule that I teach my students. That is, if a hearing loss is more than 70 dB and speech discrimination is less than 30%, that is the year which is not really serviceable. That person will not benefit too much from a hearing aid. More likely a candidate for a cochlear implant. Now, in patient with hearing loss which is exceeding this, with speech discrimination poorer than that, those patients you can think about this. Now, what are the hearing conservation procedures? What are the destructive procedures? Hearing conservation procedures classically is an endolymphatic sac decompression or a shunting. And nowadays, of course, the other procedure which you must add on to the hearing conservation, the endoscopic selective vestibular nerve section or vestibular. The destructive procedures, classically, the labyrinthectomy is also known as a three-canal labyrinthectomy and a translabyrinthine vestibular nerve section. Always, when there's a choice, a conservative procedure should always precede the destructive. This is common sense. The credit for first developing the endolymphatic sac procedure must go to Rogers, who as early as 1927 described the endolymphatic sac section. And he showed that in this series, vertigo frontal was seen highest more than 70%. Hearing loss was very, very minimal, so that he could preserve hearing and give very good relief for patients. Now, what are the indications for endolymphatic sac surgery? Classically, where patients got serviceable hearing and having progressive Meniere's disease, down was visible in spite of maximal medical value. And also, when there is bilateral disease, you choose the side which is worse. And also, if the patient got only hearing. So these are the classical indications for endolymphatic sac surgery. How do they work? By decreasing the buildup of endolymphatic pressure, by removing the bone around the sac. And also, it helps in the osmotic changes in pressure due to the extracellular milieu being altered around the sac, alterations in the blood supply, and also soft alters over the immune factors in the sac. Now, you could either be doing a sac decompression or you could also be doing a shunt. So one of the two possibilities can be. Generally, the anatomical landmark is used supposed to be. This is the most important structure. And you can see the lymphatic sac just below that coming off. And when you press on the dura here, you will see what is known as a tenting sac. Tenting will be going to the. Just remember, the endolymphatic sac is nothing but a reflection of the dura. Instead of 2 layers of dura, you have 4 layers of. So this is just to show you the surgery. This is the lateral canal, and you draw a line along the lateral canal, the normal line, which will, of course, go up to the sigmoid sinus. But it will transect the posterior canal. So that tells you this is the posterior canal here, and this is the normal line, and the dura is being drilled here, and you can already start to see the endolymphatic duct coming and starting to form the duct coming off the undersurface of the posterior canal. And as I said, if you press on the dura there on the duct, you will see the tenting of the duct. So this is a sure sign for you to. You can also take once you made the incision, you can also take a little bit of tissue and end up for a biopsy and confirm that you are. So once you have identified the sac, you can either uh, just leave it the decompression, or you can open it up and then do a little shunt either with to the mastoid, or some people even shunt it to the subarachnoid. This is a rare case of a Meniere's syndrome patient who was treated as Meniere's for many years with very poor results, recurring attacks. When eventually, when he came in his 30s, when he came here and did a CT, I was quite surprised to find this destructive lesion on it. So, in fact, it ended up with a papillary adenocarcinoma of the development. Since then, I've seen two more patients also with papillary adenocarcinoma, which only underlines the importance of asking for imaging. Because I've heard some people saying, why do you want to do a scan in Meniere's? What is a it's Meniere's, so why do you want to do a scan? Well, this is why you need to do a scan. You really need to rule out this possibility. Very rare, of course, but it's early diagnosis makes all the difference. It's very treatable. You can surgically excise the lesion, and then they give some post-op radiation. They do very well. They are normal. The vestibular nerve section is the next surgery which I will talk about. And idea is that you completely transect the nerve, so you cut off the vestibular input from the offending lateral, and so that compensation can be more effective. It was very surprising to know that this is by no means a recent operation. As early as 1895, 98, Cross from Germany, the first eighth nerve section. In 1924, Dandy, who was a very well-known surgeon, he dissected, did this for Meniere's disease, patient with Meniere's. And Mackenzie in 31 introduced the concept of sectioning the vestibular nerve alone, preserving the cochlear nerve and the facial side of it. Indications today are in unilateral Meniere's disease, again with incapacitating vertigo despite maximum medical therapy. And in the bilateral disease, if you can identify the dominant side and the offending side, then you can do this because the selective vestibular nerve side. And also in persistent vertigo, unilateral peripheral vertigo, where you cannot, it doesn't fulfill all the criteria of many years, but sufficiently disturbing and not responding. So vestibular neuronitis, recurrent vestibular neuronitis, traumatic labyrinthitis, failed intratympanic gentamicin, and even after successful stepidotomy, patients got good hearing, but it's prone for recurrent vertigo. You want to preserve the hearing, but translate to the vestibular. So you can have a middle cranial fossa approach or a posterior fossa approach. And today, of course, this is the preferred technique in endoscopic vestibular neurotomy. You can also combine vestibular nerve section along with lateral. And in a selective vestibular nerve section, you have excellent vertigo control. Over 90% of patients, provided your diagnosis is correct. And your hearing preservation also is very, very good, most of them. There is a 5% risk of severe hearing loss because of the procedure. Usually it's because of concussion of the cochlear nerve. Patient of injury is very, very rare. Now, endoscopic selective vestibular neuronectomy is, as I said, a minimally invasive technique. And let's look at the way it's done. This is an endoscopic approach, sigmoid approach. A small window has been made, and you can identify the vestibular cochlear nerve. And behind that, of course, is the facial nerve. Generally, you can identify a groove. You put a blunt instrument, press on it, you will see a subtle groove in between the cochlear and the vestibular nerve. The vestibular nerve is superior, the cochlear nerve is inferior. So you transect the vestibular nerve till the groove, till the ends swing up. So that tells you that the translation of the nerve is complete. Cochlear nerve has been preserved. So you can see the cochlear nerve is preserved, and the cut ends have gone to two sides of the gap. That tells you that nerve translation is. Now, what about labyrinthectomy? Here, all the five neuroepithelial organs have to be, that is the utricular macula, saccular macula, and all the ampullated ends of the semicircular canals have to be open. You get a good vertigo. It's almost as good as a vestibular nerve section. Slightly, maybe less. Then there's lower incidence of disequilibrium than you get with chemical therapy. Many of the patients. So again, the same indication as we said, single side, profound hearing loss. Here, the hearing loss is complete. So you can destroy the inner ear, so you cannot preserve the hearing. And you can also combine it with the cochlear implant or do a cochlear implant in the future. So here, this is roughly the anatomy section of the cadaver, and you can see that we can also see solid. A translabyrinthine vestibular nerve section, of course, combines the labyrinthectomy with the section of the nerve. And the main advantage is over labyrinthectomy alone is that it avoids a post-labyrinthectomy traumatic and small patients. But your control is well over 90%. Right. Let's go into the actual procedure. This is the patient's left side, the mastoid. You see, you can also use a C shape. Extend it a little bit higher up because you want to harvest a good patient for later repair. Having a CSFP. In our center, we generally advise this. I ask our anesthetists to hyperventilate the patients, give the ETC to low, and we also give it a mannitol. We do. So we give mannitol also to lower the CSF pressure. And so here I've done an anterior flap, alveolar flap, later for closing the. You can. There are various ways of doing it. You can either do a canal wall up or a canal wall down procedure, but we generally prefer a canal wall down procedure because many of them we also combine with the cochlear implant. And you get a much better safety by completely isolating the ear from the so we plug the station at the end of it and snap over it, right side closure. So you're completely isolated the ear from the anyway, these patients have no hearing. So, here, I'm just opening the mastoid now. And then canal wall down, all the epithelium is being removed. And then, of course, here, opening the, you can see all the epithelium is being removed with a bit of This is a facial canal in the facial bridge being lowered right down to the level of the facial nerve. You can start to see the facial nerve. And then, of course, the labyrinthectomy procedure. That's the lateral septal canal being opened now. It is ampulated in, non-ampulated in. And you can already start to see the posterior canal with the right angle. Each canal is at right angles to the other canal. So this is the posterior canal here. Superior canal is ampulla of superior canal is just next to the ampulla of the canal. All the three canals have been opened. That's the facial nerve here. Give a small rim of bone behind it and on top of it. And the labyrinthectomy proceeds till you reach the rod. You're starting to see the shadow of the rod canal. That's a rod. See the thin bone over it, covering it. Then you isolate it, you remove the bone to the side of it, so isolate it nicely. That's the horizontal part of the facial nerve, delineating angular is here. So the first part of the facial nerve would be here. That's in front of the images being outlined more and more. The superior compartment, the inferior compartment. The compartment being opened out. That bridge of bone between the two is calciform crest. Vestibular nerve is, you can see, is just here. We are going from behind, so the vestibular nerve will be first we encounter. And this bit of bone, which is separating the facial from the vestibular here, is a Bill's spur. Here, I'm just opening out this big. You can already see the facial nerve in the distance inside. That pinkish structure there is the facial nerve. And this bone covering it is the Bill's part. The vestibular nerve is attached to it. Of course, the vestibular nerve is disconnected because you already destroyed the end organ from which it comes to the vestibule. That's superior canal here. Inferior canal, inferior compartment, inferior vestibular nerve being slowly removed. Here you can see the cochlear nerve. The whitish structure there is a cochlear nerve. The color is very distinct. Cochlear nerve is a pearly white structure, and here you can see the singular nerve, this side of it. This there, the singular nerve. The cochlear nerve, whitish. The facial nerve is pinkish. Vestibular nerve is grayish. So the color coding is very distinctive, and it always helps. Of course, we always do this with facial nerve that your but facial nerve is well protected as the cochlear nerve. This is why you can do a cochlear implant in this patient. Very easy to open a cochlea there and just put an implant there. So that's all that you need to do. Right. So once this is done, of course, you put a fascia over it and get a bit of muscle and tissue. What about BPB? Chronic BPB, which is refractory. Several attempts at doing repositioning. Patient keeps on coming every third month. Of course, you have to check up the serum calcium, vitamin D deficiency. That can give rise to it. But apart from that, even with all that correcting, some of them have this tendency of coming every third month or second month. Now, in such patients, you can put in a little bit of fibrin glue or band tissue to the posterior canal. And also, interestingly, the people use lasers to create a bit of fibrosis. After the posterior canal is deep to the vertical part of the facial nerve, and you have to be very, very careful to the facial nerve. Singular neurectomy is a very interesting procedure, but nowadays it's not done very much because there's quite a high failure rate in these patients. Reportedly 10% failure rate, but maybe quite high because of the variations in the anatomy of the singular nerves. It's always open near the round window niche, and there's a lot of variation in the nerve in that area. Vascular compression syndromes, you can see an ICA which is commonly looping around the nerve, especially the vestibular cochlear bundle, and may give rise to a disabling position. Microvascular decompression, the endoscopic approach, in ICA you can see 7th and E. And all you have to do is give a bit of gelatin sponge. Extra-axial lesion to the cerebellocondylar angle, particularly vestibular schwannoma. And again, we do a translabyrinthine approach. Again, already faster. And here you have to be, much more bone removal than just a vestibular nerve section. You got to do the entire bone covering the posterior fossa as well as the middle fossa. And the moment you open up the meatus, you start seeing the tumor. In our center, we always leave the tumor removal to the neurosurgeon. So we do the exposure and give the tumor to them and then ask them to do it. Not because you can't remove it, but because it's much better to have a collaboration like that. Because the complications invariably are all neurosurgical, and you need to have them on board. And also, it's always good to have a team working because it takes time and team to have them on board. So this is how we function. So here the tumor is being removed, the last bit of it, always with the patient on monitor. It's also possible in many cases to preserve the cochlear nerve. So in which case you can put a cochlear nerve. But if the problem of this anatomical preservation of the cochlear nerve is not always synonymous as functional. You may have preserved anatomically, but sometimes the cochlear nerve may still not function. So once the tumor is removed, the patient is healing up, the CS is bleeding, then the neurons are brought together. Finally, vestibular implants, it's a modified cochlear implant. Looks like this tissue, each for one semicircular canal. and electrodes are implanted into the apple of the sensor. An external part instead of the speech processor cochlear implant, you have a gyroscope, measures head movements and gives signal. So when are you doing it? In basically patients with bilateral vestibular ear defects, bilateral vestibulopathy, where you want to at least compensate one side. Finally, concluding, surgery is indicated in a small proportion of patients whom vertigo is refractory. Treatment has to be individualized, and you have to have very stringent selection criteria depending on the appropriate surgery. Most counsel these patients, right? Try to take them.
Thank you, sir, for the excellent deliberation. It is always a pleasure to hear you speak, sir. May I now request Srinivas, sir, to make a quick comment?
There is nothing to comment there. It is a complete presentation by a man who has all the cases and by a man who does all the cases.
Right. Count, sir?
Great talk. Superb it was. Thank you, sir. Thank you so much, sir.
Count, sir?
Yes.
I know what it will be like. That's why I requested sir to speak on this subject. I have heard him earlier. It's always excellent. And he's covered everything. There's nothing left. Thank you so much, sir.
Thank you. Thank you.
Thank you, sir. Thank you, sir.
So we'll reserve the discussion for the question and answers round. Okay. So moving ahead with our next talk, it's on vestibular migraine. What is it? Hiding in plain sight by Dr. Surajit Burman, sir. Let me make a quick introduction of Burman, sir. Having accomplished his post-graduation degree from Assam Medical College, Dibrugarh in 2006, he has received training in neuro-otology under Dr. Anirban Vishwas, sir, in 2010. He is currently working as a consultant in charge of the Vertigo Clinic in Nightingale Hospital, Guwahati. He is the director of GVSB Group. He has organized workshops on vertigo management and maneuvers in NES 2017 Jodhpur, BalanceCon 2017, Bengaluru, Shillong 2017, and in Guwahati 2010 to 19. He has been the invited faculty at BalanceCon 2017, 18, and 19. He has also been the invited faculty at NES 2018 and NES 2019. He has many publications to his credit, numerous presentations at regional, national, and international conferences. He has been awarded as the S. Kumar Award in Neboicon 2007, the L.H. Hiranandani Award in Neboicon 2017. He has been the past editor of Annual Journal of Neboi. May I now request Surajit Burman, sir, to come in and make his presentation.
Thank you, Sanchita. A very good evening to all. Just give me a second to share my screen. I hope everybody is having a look at my screen. They're seeing it.
Yeah.
Okay. So, as already said, a very good evening to all the faculties present, the delegates who are watching it, either through our LiveMate website or through YouTube. So the choice or the subject that I am supposed to talk on is vestibular migraine. The heading that has been given to this topic is hiding in plain sight. Vestibular migraine, what is it? Now, first of all, let's tackle on what is it. Vestibular migraine is a variant of migraine that include a number of debilitating symptoms affecting the ears, vision, and balance. Headache may or may not be present. Now, why is it called hiding in plain sight? Well, the reason for this is the second most common cause of vertigo in a clinic, in many clinics. In many clinics, it's actually the first. I think Dr. Vishal has a presentation where in his clinic, this is by far the most common. It has now been recognized that over 1% of general population suffers from this condition. This was a paper by Neuhauser et al. In 2006. 1 year incidence is 0.9 to 3.2%, seen in 9 to 47% of migraine patients, most common cause of childhood vertigo, and can occur in any age. This is how common it is, and yet most practitioners have difficulty in identifying this condition and diagnosing this condition. It has, and it's not like it is new thing. It was way back in 131 BC where Eratosthenes of Cappadocia first described it. However, there's a big gap, and the next time it is mentioned in literature is in the 19th century, when in the year 1873 a paper was published titled Sick Headache and Other Allied Health Disorders by E. Living et al. Proper study has still eluded it, and it was only in the late 20th century, as late as 1981, where Kuridze et al. Made a paper, followed in 1984 by Kayan et al. Diagnostic criteria for this took even longer, and it was only in the year 2012 that the consensus document of Barony Society and the International Headache Society came up with the diagnostic criteria needed to diagnose definite diagnosis of vestibular migraine. What are these diagnostic criteria? They have divided it basically into two. The definite vestibular migraine, where there are four diagnostic criteria. Criteria A is at least 5 episodes with vestibular migraine of moderate or severe intensity lasting 5 minutes to up to 72 hours. Current or previous history of migraine with or without aura, according to International Classification of Headache Disorders. One or more migraine features with at least 50% of the vestibular episodes. Headache with at least 2 of the following characteristics: one-sided location, pulsating quality, moderate or severe pain intensity, aggravation by routine physical activity, photophobia and phonophobia must be present, and there must be visual aura. Of course, none of these symptoms must be accounted for by another vestibular or ICHD diagnosis. Probable vestibular migraine has almost similar criteria. Criteria A is same, at least 5 episodes with vestibular symptoms of moderate or severe intensity lasting 5 minutes to 72 hours. However, criterion B and C both need not be present, and if even one of them is present, it is termed as probable vestibular migraine. Of course, the last criteria of it not being accounted by any other vestibular ICHD diagnosis still stays. Now, the pathophysiology of vestibular migraine. We all know there have been a lot of studies and a lot of postulations regarding the pathophysiology of migraine. However, regarding the pathophysiology of vestibular migraine, it's even more uncertain. There are numerous theories going around, to the extent that in 2030, Professor Forum in the Lancet published an article where he specifically mentioned that the pathophysiology of vestibular migraine is incompletely understood, but possibly could include neuroanatomical pathways to and from the central vestibular structures and neurochemical modulation via the locus coeruleus and raphe nuclei. The numerous confusing pathophysiological pathway has for years been giving a lot of confusion, has been creating a lot of confusion. Finally, in 2015, Equese Sanchez et al. Published this. They postulated that there is intermingling of two separate pathways. The inherited brain excitability sensation pathway, which is basically uses the thalamocortical pathway for processing the cognitive and perceptive changes, and the amygdala and insula to process the emotional response and spatial memory changes, and the trigeminal-vascular reflex, which through the trigeminal pain pathway activation is modulated by the CGRP substance P neurokinin A. Now, this comes to importance later when you're talking about treatment, leading to vasodilation of inner ear blood vessels. Now, whenever there is any problem or anything wrong with these two systems, there is cochlear or vestibular hypersensitivity, leading to vestibular dysfunction, which results in sensorimeter responses in eye, head, and gait. Now, the clinical presentation of vestibular migraine, it can involve a combination of lot. It has been called one of the greatest mimics of the vestibular disease spectrum. Vestibular migraine can have the following symptoms. It can be associated with migraine headache symptoms such as severe throbbing headache, usually on one side of the head, but it is not always there. Nausea and vomiting is usually there. Sensitivity to light, that is photophobia, smell and noise, as already mentioned, is photophobia, and phonophobia is usually there. Vestibular symptoms may include vertigo or dizziness, usually lasting minutes to hours, as already mentioned. in the diagnostic criteria, and it can last even up to days, 72 hours. Unsteadiness and loss of balance is, of course, very common, and sensitivity to motion is seen. It is said that a person who has motion sickness tend to develop vestibular migraine on later stages of life. Now, we all know the stages of a headache, migrainous headache. It has the prodrome phase, the headache phase, the resolution phase, and the postdrome phase. However, vestibular migraine does not seem to have any specific staging. It can be present in any of these stages. It can be present for any time. It's not like that the same, each person will have the same amount. Like, it's not like one person, if it has one attack today of 5 minutes, his next attack is also going to be 5 minutes. It may be 5 minutes today and 3 days tomorrow, and 2 hours a few days later, or it may be 5 minutes today and then another 6 months nothing else, and 6 months down the line he may have a 3 hour attack. So there's a lot of differences in the attack postures of the migraine disorder, vestibular migraine disorder. Now, coming to management, the most important management in any migrainous disorders, be it migrainous headache or vestibular migraine, is behavior or lifestyle modification. Excuse me. Sorry. Of course, pharmacotherapy plays a very important role, and there are a lot of newer approaches coming in. As already mentioned, behavioral therapy includes education, understanding and removal of the trigger mechanism, taking care of nutrition, and other behavioral therapy. Sorry, I'll just take a sip of water. Preventive drugs are mostly beta blockers and anti-epileptics. And of course, acute treatment can be non-specific, anti-vertigo treatments or antiemetic treatments. As already mentioned, one of the most important factor in the treatment, long-term treatment of vestibular migraine is removal of trigger factors. Of this, the most important is regularity. Now, what do we mean by regularity? What it means is that everything in that person's life has to follow a regular protocol. His right from his getting up to sleeping at night, his food habits, his daily habits has to be very regular, because at the second point highlights, anything that is too fast, too sudden, or too much can trigger migraine. So the patient who is suffering has to remember that his daily schedule should be very meticulously followed. His regular day and night rhythm has to be maintained. The present day, of course, not during this COVID pandemic, but before that, and maybe very soon after this pandemic is gone, many people, especially the age group in which vestibular migraine is common, in the youth and the young adults, the day-to-day rhythm is very disturbed. They will be having different rhythms for different days of the week. So this cannot be tolerated, and this has to be eliminated. And this is very important. 100% is sufficient. That means giving 100% or maintaining 100% regularity is the only option. If you maintain even 1% less, that trigger may be coming in, and the vestibular migraine episode will be trivialized. And stabilizing the energy metabolism. Now, there are different fads nowadays, this diet and that diet and that diet. However, a patient who is suffering from vestibular migraine, or for that matter migraine, has to be properly given proper nutrition. So this is where the next point comes in. Regular and fixed times of food, the breakfast, lunch, dinner. There has to be small regular meals, maybe at a gap of 3.5 hours. Breakfast has to be the most important meal. The old adage, breakfast is like a king, has to be followed. Now, eating of carbohydrates is also important, but in some people, this tend to trigger migraine. Some people it doesn't. But we have to remember the fads of modern day diets of only eating this and that. No, the diet has to be balanced. Eating slowly, drinking lots of fluids is important. So the traditional way of eating food is more important than the modern way of eating at the go. That is not going to happen. Coffee is very problematic for headache, but it does not have much of a role in the triggering of vestibular migraine. Now, acute management. Acute management is managing the nausea, the vomiting. So here, drugs like prochlorperazine, cinnarizine, beta-histine, dimenhydrinate, maclizine, these are the potent antihistaminics, the anti-vertigos and the anti-emetic drugs are of utmost importance. But this is acute management. Something that I did not add in the slide, antipsychotic medicines, SSRIs in low doses, because most of these patients are already very anxiety prone, and the disease itself will trigger anxiety. The anxiety is a trigger and the disease triggers anxiety. So there's a vicious cycle going on. So we have to, in many cases, add some amount of SSRIs also in acute management. But there are different pros and cons of the acute management. What are the positives? Of course, rapid onset of action. The patient vertigo goes off and he or she is very good. It's relatively inexpensive because we're taking 1 or 2 tablets, and it's ideal for people who suffer from occasional migraines. We'll be coming to that in a few minutes. How do we divide that? However, the negatives, it does not address the frequency of attacks or impact the quality of life. Now, this statement, the most important thing to address this is actually taking the lifestyle modification. If not taken at the very onset, it is less effective. So once you have a full-blown dizziness, you may need very high medicines, and taking a small tablets may not help you. Acute therapies in many patients are not always effective. They do need preventive medications, and every medicines have undesirable side effects. Now, the problem in, especially in vestibular migraine, is people who have 1 or 2 attacks have taken a dose of a cinnarizine or any other antivertigo drug, or beta-histine or any of those. They tend to get that idea that taking this medicine helps me. So we see in our practice a lot of patients who start taking these anti-vertigo drugs as preventive medicines. They say, today I have this workshop going on, today I have that marriage to attend, or I have a very important meeting in office. So though I do not have vertigo now, because I'm afraid it may attack me, then I've started taking 1 tablet of either a beta-histine or a cinnarizine or one or whatever, prochlorperazine, before the attack starts. Now that is actually not correct. So we have to be give very importance to that. Now, what is preventive management? Vestibular migraine is a preventable condition. Of course, one of the most primary importance in preventive management is taking care of the triggers. But when we talk of pharmacological preventive management, we have to know when to use them and what medications to use. Now, first, let's talk about when to use. Unfortunately, there is not many studies regarding when we can use medicines in vestibular migraine. So, what we need to do is uh, look at studies where we find out what are the guidelines of taking medicines in vestibular, not vestibular migraine, but in migrainous headaches, and maybe bring those criterias while treating patient with vestibular migraine. So what are those criterias? There are a lot of criterias. We have the American Association of Neurology guidelines, we have the European Federation of Neuroscience guidelines, we have the US Headache Consortium, we have the Italian Headache Consortium, you have the Canadian headache, but these are all basically headache related. However, we can, because these are basically towards migraine, and we are talking about anti-migraine therapy and not only for the vertigo therapy, we can use this as a basic guideline for using them in preventive long-term medications. So how do we recommend? Candidates for migraine prevention are recommended based on 2 things: symptomatic days per month experienced by migraine patients and level of attack related impairment caused by these symptoms. So they are divided into 3 groups. Group A, where prevention should definitely be over. These are migraine subjects reporting either 6 or more symptomatic days per month, 4 or more symptomatic days with at least some impairment, or 3 or more symptomatic days with severe impairment or requiring bed rest. Where this can be considered, the um, choice has been left to the prescribing consultant, where patients with 4 or 5 migraine days per month with normal functioning, or 3 migraine days with some impairment, or 2 migraine days with severe impairment. And where they should not be indicated, long-term therapy is not indicated, and where, as I mentioned, in the pros of acute therapy is in itself enough, is migraineurs with less than 4 symptomatic days per month and no impairment, or subject with no more than 1 symptomatic day per month regarding that, regardless of the impairment. So what is pharmacotherapy? Now, the pharmacotherapy in migraine, we all know, has been divided basically into four groups. There were the level A, B, C, and U drugs. Now, these are the recommendation of American Headache Society, and this is based on the FDA approval. So here we have the anti-epileptic drugs like sodium valproate, topiramate, beta blockers like metoprolol, propranolol, and timolol. However, every other than the US guidelines has put flunarizine in level A. Unfortunately, flunarizine is not FDA approved. So most of the American studies will not see flunarizine, but it is a level A drug. Level B drugs are antidepressants like amitriptyline and venlafaxine. Till a few years ago, amitriptyline was actually in level A. However, recent studies have put it in level B. Beta blockers like atenolol and nadolol have been also put in group B. Group C are ACE inhibitors like lisinopril, angiotensin receptor blockers, antihistaminic, antiepileptics. And level U, where we do not have adequate data or conflicting data, is acetazolamide, drugs like gabapentin, fluoxetine, as far as their anti-vestibular migraine properties are concerned. So a few words about CGRP. We had already talked about how that trigeminal pathway, any problem is responsible for starting triggering migraine, vestibular migraine attacks. So CGRP agonist has the potential as anti-migraine use. FDA has approved it just 2 years back in 2018, where it has used a molecule called erinubab, which attacks the CGRP receptors, and fremanuzab and galacnuzab, which attacks the CGRP molecules, as they have been given FDA approvals. However, number one, these are very new drugs, and number two, you need it for a long time. Treatment is needed for 6 months to 12 months, and cost of treatment per dose in Indian currency comes from anywhere between 8-9,000 to up to 45,000. So it's very costly. It's not for the Indian market. It's very difficult. Other therapies include traditional remedies like acupuncture, Reiki, Ayurvedic formulation. Surgeries have been mentioned in many papers where I did this. I don't know of anybody doing surgeries per se for vestibular migraine. Neuromodulation came in a huge few years back, but recent studies, number of studies have put it at the same level as placebo. So I think it's not no longer used too much. Now, here I'd like to present a small study that we did a few years back ago. It was in 2018. I had presented this in the Vertigo Academy International in Mumbai, where it was a small study of 35 patients who, according to Barony Society's classification, had definite vestibular migraine and was treated with propranolol and flunarizine. Most of these patients got propranolol. Now, the patients had basically frank vertigo, 23 patients, 10 patients as non-vertiginous dizziness, nausea, and vomiting was seen in 31, and associated headache was seen in 27 patients. However, the treatment, 100% successful in treating the frank vertigo. Non-vertiginous dizziness was better in 10 of the 12 patients, that's 83%. Nausea and vomiting in all the patients, 31 patients that complained, and headache in 26 of the 27 patients that complained. No patient recorded worsening of the symptoms. Now, if we compare my study, the study that was done in our hospital with the studies that have been present all around, we see that studies that was done in 1980 by Johnson et al. He had used medicine which was able to give remission of the migrainous vestibular migraine in 92% of the cases. The study by Raploig et al. In 2002 had used a number of things: medications, acupuncture, diet modification, neurology consultation. In this, diet alone was responsible in ameliorating 13 of 81 patients. Diet plus antidepressant in 24 of 31 patients, antidepressant and beta blockers in 21 of 27. Bikazi et al. In 1997 had a big paper on with 58 patients, beta blockers, calcium channel blockers, tricyclic antidepressant, and they saw substantial improvement with this combination. Baer et al. Used 26 non-pharmacological and 74 patients with pharmacological beta block thing. They had 100 patients. They found that the better results was got with the pharmaceutical management. There's 37 patients in the study by Seliker et al. In 2007. They had used valproic acid for 3 months. There was marked improvement, but what is important was ENG findings did not show any difference. Kemona and Cietis in 2005, topiramide was used in 100 milligram at 100 milligram in 10 patients. There was remission. Bisdoff in 2004, 19 patients had used remotrigine every morning for 2 weeks, then 25 mg for 2 weeks, and then 50 mg for 2 weeks. There was significant reduction. Waterson in 16 patients with medications saw complete or marked reduction. And like already mentioned, this is a group U drug, acetazolamide, but Bello et al. In 1996, in a very small group of 5 patients, saw marked improvement with acetazolamide. Now, what are the differential diagnoses? Now, to put Meniere's disease in a differential diagnosis, because Meniere's disease is still considered by some authors to be one end of the spectrum of in the whole spectrum, where the other end is vestibular migraine. So many consider Meniere's disease and vestibular migraine to be two ends of the same spectrum. So whether it will fall in, whether Meniere's disease is just a variant of vestibular migraine or vestibular migraine is a variant of Meniere's disease, there's a lot of controversy in that. Somatoform vertigo, either primary or secondary. By primary, we mean direct somatoform vertigo, or somatoform vertigo developing in patients who initially had an attack of vestibular migraine is seen. BPPV is commonly mistaken. Why? Now you'll say, how can someone mistake BPPV? But positioning vertigo, not positional. Positional vertigo is seen in vestibular migraine also, although positional can also be seen. We have had patients showing typical nystagmus patterns of BPPV and later on getting better with anti-migrainous therapy and not with the typical maneuvers. TIA, syncope, orthostatic hypotension, vestibular paroxysmia, episodic ataxia type 2, bacillar type migraine. These are all part of the differential diagnosis spectrum of vestibular migraine. Now, to conclude, vestibular migraine is the second most common cause of vertigo. Diagnostic criteria is now available. However, still then, misdiagnosis is very common. We do get many patients who have been treated with as BPPV, as Meniere's disease, as vestibulopathies, who on proper history taking, we find it to be case of vestibular migraine. So management is very important, and management definition, which is acute management, what is preventive management, is very important. The preventive therapy is never going to take care of an acute episode, and the acute management should never be used as a preventive therapy. This is very important. Now, before ending my slides, I have to say something, and this may not directly relate to vestibular migraine, but this relates to the present workshop that is going on, this online workshop, because someone else here is also present who is hiding in plain sight. This person has been as much instrumental in the running of this webinar as either Gautam Khansar or me. You see this webinar because of him, you hear this webinar because of him, and he's the idea and brain behind this. And that is why I dedicate my talk today to Dr. Biswajit Gogol. Thank you very much.
Thank you, Surajit. Yes, thank you, Surajit. Before Dr. Vijay V. Gogol comes along, I request Dr. Srinivas and Dr. Kameshwaran for any comments. And Sanchita has had to go home, so Mr. Surajit will have to introduce Dr. Vijay after the comments from our chief faculty.
Yeah. Commissioner, sir?
Yeah.
Yes, sir.
Yes, yes.
Yes, sir.
I really enjoyed the talk. I think it's wonderful summary. Surajit did a beautiful job. So, if there are any questions, I think you should address them. But I think, yeah, I mean, it's very self-explanatory. His talk has covered the whole area so well. It's one of the very common problems, and I think all of us have to be aware of it. I would say it is one of the commonest problems that you'll be seeing in your practice. So, it's a very practical talk, and I think very, very useful.
Thank you, sir. Thank you, sir.
Thank you very much.
It was a wonderful presentation, Dr. Surajit, as usual. As usual. Thank you.
And we also any comments for the first talk, because we passed on immediately. Zulfi
Okay. Oh, I thought we'll make all the analysis at the end, but then if we want, then I'll right away do that. Okay. Okay. So Dr. Zulfi's was very well-rounded talk. In fact, he started off very, very beautifully by telling that functional disorders and psychiatric disorders are not one and the same. And that was a very, very beautiful point. He started off from there, and then he built the topic using all the multiple criteria, the way in which this dizziness has been, the classification has progressed. Then he made a beautiful point again, stressing very much that it is not a diagnostic. Triple PD is not a diagnosis of exclusion. Rather, you should have positive findings. Very, very beautifully explained. And then he gave multiple methods of treatment, including cognitive behavioral therapy. And very nice thing, very novel thing that he presented today was about the optokinetic therapy. So which is very new. Okay, not usually we come across that. Thank you for introducing us to a totally new method for therapy. And then Mohan Kameswaran sir, there is absolutely nothing more in to be covered in the topic. Everything is there covered. Okay, for a long, long time, this is going to be that topic on surgical management of vertigo, which is going to remain relevant for decades to come. Everything is covered. Okay, both historical surgeries and the surgeries that are doing. The best part is that he has presented his own cases. Okay, and he has a variety of cases in his own work. Okay, and you don't see you, and in fact there is that kind of a thing is you can't, it's not paralleled anywhere else. Okay, across the globe for that matter. Okay, so that is excellent. And then Dr. Surajit. Okay, the best part is the treatment, which I agree with him. The best medication for migraine, he started off food in time. And yes, exactly. Okay, so which tells so. And then the triphasic pattern, or three temporal patterns in migraine. Okay, he stressed and he told to keep that in mind. And of course, all the different societies criteria, that was almost complete. And the final point about the final slide about all the drugs that we can use. Okay, that is one thing that I have actually taken a screenshot and kept. Everybody should take a screenshot and keep that, because what happens is our armamentarium when it comes to vertiginous migraine is generally limited to one drug, two drug, maximum three drugs. But then if they fail, we don't have anything else to offer, and the patient remains frustrated. So we should have the entire, our armor should be filled with all different kinds of arrows. And that particular slide, you have to take a screenshot and keep it. I have done that. I think if you have not done that, maybe we can share it there so that everybody can keep it. It is going to guide. Okay. So thank you so much. And I think we'll proceed with the next talk. No, before that, I think we should ask Dr. Mohan Kameswaran sir's comments on the first talk.
No, no, I think you covered it very well, Srinivas. You summarized it for us. I really enjoyed all the talks. I've learned a lot, I must say. Really quite informative. I'm sure everybody's learned. I certainly have learned from all the talks before and after me. Very informative. Very, very good.
Thank you, sir. Thank you.
Thank you, sir. Thank you for Dr. Srinivas sir and Mohan sir. The comments from you really lifts us up. Thank you very much, sir. So thank you, sir. So we'll straight away go to the next talk. The next talk is to be presented by Dr. Vijay Vinayak Ghuge. He is from Nasik. So a brief introduction. When I had requested Dr. Ghuge for his CV, he had just sent me 4 lines. Name, Dr. Vijay Vinayak Vishwanath Ghuge, Education MBBS, MD Medicine, DM Neurology. Workplace, Vishwanath Neuro and ENT Care, Vertigo Clinic, Nasik. Area of special interest, vertigo and headache. Publication 4. I called him up, sir, such a small CV. And he said, sir, talk hi to dena hai. I'll let my talk do the talking. So I'll straight away ask Ghuge sir to come present his talk, because he is presenting in a very different way. Thank you, sir. Please share your screen, sir. Guge sir, you are muted. Please unmute yourself, sir.
Am I audible, sir?
Yes, sir.
Okay.
Sure, sir.
Thank you, sir, for kind introduction. Basically, I did my MBBS and MD medicine from Mumbai. Sage GS Medical College was my MBBS college, and KM Hospital, Mumbai. Sion Hospital is I did my post graduation, and from Maulana Azad Medical College and GP Pant Hospital, New Delhi, I did my DM.
No, sir. We can hear you. We can hear you now, sir.
Yeah, sir.
We can
Thank
hear you, sir. Abhi,
Yeah.
this is not.
My screen is visible, sir.
Yes, sir. We can see your screen, sir.
Okay. Sir has given me, thank you, Surajit sir, for giving me such an opportunity. This is one of the most difficult topic in neurology. If you go into the theory of this topic, then it becomes very boring. So I have given a brief introduction of few terminologies used in stance and gait disorder, so that one can be familiar with how to examine the gait patient and which are the different terminologies one should use while describing the gait. So the topic name which was given, when the going gets tough, it's really tough both for the neurologist as well as my friends in the ENT. So what are the essential component of the gait? Gait refers to the manner or style of walking. So the few terminologies like what is equilibrium? Equilibrium is the ability to assume the upright posture and to maintain the balance. That means your equilibrium. What is the locomotion? It is the ability to initiate and maintain the rhythmic stepping. For that, one should require musculoskeletal integrity. That means normal bone, joint, and muscle function. This whole thing is modulated by neurological control. That is your visual, vestibular, auditory, and sensory motor input. So what is the gait cycle? It is a very simple. Gait cycle refer to all activity that occur between two successive heel contact of the same foot. That means if we are referred right feet, heel contact of the right feet first, and then second time when heel contact occur, whatever occur in between, it is your gait cycle. It consists of stance phase and swing phase. Stance phase means your leg is in contact with the ground, and swing phase when it is not in the contact. The duration of the complete gait cycle is known as a cycle time, which further divided into swing and stance phase. So what are the different terminologies used in describing the gait? The first one is stance, that is support phase, occur when the foot is on the ground and accounting for 60% of gait cycle. It begin with heel strike and end with toe off of the same foot. The stance is that period of the time when foot is in contact with the ground. If you see, here are the representative figures, that is heel strike, foot flat, mid stance, and heel off and toe off. The toe off is sometimes the late part of the toe off we can consider is at the early swing phase or acceleration phase. Now the second phase is swing phase, which is unsupported phase. The phase occur when the foot is not in contact on the ground, accounting for the 40% of the gait cycle. It begins when the foot leave the floor and end with the hello. Sorry. And ends with the heel strike of the same foot. The swing phase consists of acceleration phase, mid swing, and deceleration. So here are the different stages of the gait cycle. Here there is a heel strike, then full loading, that is foot flat, mid stance, terminal stance, that means heel of pre-swing phase, then initial or mid swing and terminal swing. The swing phase consists of 40% and support or stance phase consists of the 60% of the cycle. The double support occur when the both feet are in the contact with the cycle, consists of 20% of the gait cycle. These are the different terminology: stride length, step length, and step width. the stride length is distance between two consecutive heel strike of the same foot. Approximately in normal individual, it is around 1.4 meter. Step length is a distance between the heel strike of the opposite foot, and step width is a stride width, or it is also known as walking base or base support. It is the distance between two medial malleoli of the 2 feet when they placed together. So this is a stride. That means heel strike of the same foot, the distance between the heel strike of the same foot, it is known as stride. And step is, this is the right step basically, heel strike of the right foot and heel strike of the left foot, distance between them, it is known as a step length. What is the cadence? Cadence is the walking speed, that is a number of steps taken per minute. The walking rate is classified as slow when when there is 75 to 90 steps per minute. Medium is 90 to 105 steps per minute, and fast is 105 to 120 steps per minute. Normal healthy individual can walk 113 steps per minute. Why this is important? When we say is slow, walking is slow, then we should think in terms of how many steps patients take in 1 minute of time. So then and then we can label it as a slow, medium, or fast. So while describing it, we should have a look on these 5 parameters, like how patient arising to standing position from seated position or lying down position. That will indicate whether there is any proximal muscle strength weakness, like waddling gait in myopathies. Organization, how his trunk or his limb movement, and stability of the stance during the standing phase. Then what is the posture of the patient while standing? What is the stance base, that is width of the base? What is the architecture of the body, whether patient is swaying here and there, what is there on Romberg sign, and what are the postural reflexes? Postural reflexes predominantly pull test, that is very useful in patients like Parkinson plus syndrome, like multi-system atrophy or progressive supranuclear palsy. Then how patients start walking, that is how there is an initiation of the walking, what is the speed of the walking, what is the stance based step length, cadence, and step trajectory, how patient is walking, shuffling, or whether there is any high stepping, shallow, and whether there is associated any trunk posturing. Then another most important thing is how patient turn while walking, because turning is very important for the neurological point of view. Whenever we see the Parkinson syndrome or Parkinson plus syndrome, the turning, how patient turn, it is most important thing which will indicate few disorders. Like then we can identify how Parkinson plus syndrome, in which Parkinson plus syndrome patient is fitting. It consists of how number of steps patient taken while turning, how patient is step, whether there is any en bloc turning or whether there is any freezing. Then another thing, whenever you suspect whether there is a cerebral ataxia or something like that, then how patient start walking, whether there is tandem, how patient walk tandem walking, walking backward. It is very important thing. Whenever you suspect some dystonias, always ask young patient with foot onset dystonia to walk backwards, because it indicates some diagnosis. I will show all these videos, whatever I have described, how walking backward is important, and how you can clue to the diagnosis, what is the patient is having. Now there are this is a very simple classification of gait disorder, that is lower level gait disorder, middle level gait disorder, and higher level. Lower level means your vestibular system, proprioceptive system, and your musculoskeletal and visual system. So whenever patient is having peripheral neuropathy, or patient is having some sort of myopathy or some musculoskeletal problem, what kind of gait disorders occur, we can label them as a lower level gait disorder. Then second part is middle level gait disorder, where there is efferent and afferent sensory motor pathways, that means basal ganglia system, your brainstem, your cerebellum, and your spinal cord. It consists of hemiplegic gait, paraplegic gait, cerebellar ataxic gait, Parkinsonian gait, and various movement disorder like choreiform gait and dystonic gait. These are also known as hyperkinetic gait disorder, because chorea and dystonia are hyperkinetic uh, disorders. Then higher level gait disorders. Higher level gait disorders may when there is involvement of the cortical area. Basically, patient with frontal lobe disorder can have a this kind of gait disorder. In such cases, sometimes people not label it as a gait disorder, but they label it as a apraxia. That means difficulty in doing the certain clinical task which patient was able to do previously. Here, since higher cortical areas are involved, patient's gait is cautious gait. Uh, so subcortical structure sometimes involvement is there, like Bence-Schwingers syndrome can have such kind of gait. So these are the gross clinical feature, various gait problems. In cerebellar gait disorder, patient have a lean forward posturing, wide base. Postural reflexes may be variable. In cerebellar disorder, gait initiation is normal. Step are staggering and lurching. Speed is normal. Most of the patient have speed normal, but because they have a fear of fall, so speed is normal but slow. Heel to toe, they are not able to do heel to toe walking. Their tandem walk is also impaired. Heel to toe walks means tandem walk. Turning, they have some wearing while turning. Rombox test most of the time is normal. Heel shield, heel to shin test is most of the time abnormal, and patient does not have any fall. Sensory ataxia means those patients which having peripheral neuropathies. They have forward stoop posturing and wide base, but their postural reflex is normal. Gait initiation is normal. Sometimes, if there is a foot drop, then patient having high stepping gait. In such patients, speed is normal. Predominantly Rombox sign. Whenever you see such patient, always do a Rombox test. If that is positive, that goes more in favor of sensory ataxia. Rombox test is basically for to determine the sensory ataxia. In frontal lobe disorder, that is higher gait disorder, patient is generally having upright posture, wide base gait, impaired postural reflexes predominantly. Pull test is most of the time positive in such patients. Whenever you stand behind the patient and you pull their shoulder, the patient is having fall. That is pull test. Patient is having start hesitation. Whenever you examine clinically on the bed, patient is absolutely normal. But whenever patient start walking, at that time his foot like a glued to the ground, which is also known as magnetic gait. Patient is having freezing and shuffling, and Rombox test is variable in such patient, but falls are very common in such patients. So most common thing, it is how to differentiate between Parkinson disease and Parkinsonism. Parkinsonism is always symmetrical, and Parkinson's disease, that is idiopathic Parkinson disease, it is basically asymmetrical onset, and dopa responsiveness is a characteristic feature of Parkinson disease. And Parkinsonism, there is symmetrical gait, and such patients are not responsive to syndopa. But the clinically, how you distinguish, the clinically patient is having stoop posturing in Parkinson disease, and trunk is in the flexion. Here, Parkinsonism, it depends which kind of Parkinsonism. If patient is having the PSP and PSP-P syndrome, then sometimes patient is having, it is also known as Streitrager syndrome. Patient is having neck stiffness. Patient is not able to do, not able to look down towards the ground while clearing the ground. Parkinson disease patient is having narrow base, and Parkinsonism patient is having wide base. Start hesitation is a peculiar feature of Parkinson disease. It also observed in Parkinsonism. Freezing is common in both the Parkinson disease and Parkinsonism. Arm swing, unilaterally arm swing may be minimal or absent in Parkinson disease, but in Parkinson plus syndrome, bilaterally arm swing is reduced. And postural reflexes generally preserved in Parkinson disease. It is absent in symptomatic Parkinson or Parkinson plus syndrome. So whatever I have described till now, it is a totally theoretical, but I will give a representative example of each and everything on these videos. Once, since I am a neurologist, I found visual memory is always better than any auditory memory. So whatever you see, that will one should remember lifelong. So these are the all prototype example of all gait disorder. And one more thing, whatever gait disorders I will describe now, these are all treatable entities. I have one or two disorder which I will describe are non-treatable. Otherwise, everything is treatable disorder, so that one can get clinical clue and how to diagnose and treat. So this is a hemiplegic posture gait basically. He is a 60-year-old gentleman who is having left thalamic bleed, and this is the residual his gait disorder. He's having hemiparetic posturing. His arm, right side arm is flexed, adducted, internally rotated, and leg is extended. If you see from the start, you will find he's lifting his hip while right hip while walking, and there is slight circumduction. And always remember, hemiplegic patient turn from the paralyzed side. Here you can see he is turning from the right side. So from the paralytic side, he is turning. So this is typical what is known as circumduction gait or hemiplegic gait. Now see this girl. I will stop this video. I will share this. Now she had also thalamic bleed, but she is having some abnormal movement. She is having arteriovenous fistula and thalamic bleed. That fistula was embolized. But look at her right hand. She is having abnormal movement. That is basically a choreoform movement. She is having that choreoform movement in the right hand. She is also having right-sided hemiparesis and this residual right hemichuria. Now see how she is walking. See, she's slightly dragging and there is choreoform movement in her right foot. So this is a basically hyperkinetic movement disorder is present in hemiplegic circumduction gait. So this is hyperkinetic gait, choreoform gait in hemiplegic gait. Now see this gentleman. This is typical Parkinson. He is a dopa responsive idiopathic Parkinson disease. He presented with me after 6 to 7 years of treatment. I have put torch, heat stick and my hammer. Whenever he see these three objects, his gait is absolutely normal. But now see, while turning, he is having slightly shuffling and there is a festination. He takes short, quick step with forwards to posturing. He is having gait initiation problem. He is having accelerated step, difficulty in starting and difficulty to stop. But whenever he sees three-dimensional visual clue, his walking absolutely improves. This indicates this kind of feature occur late in the Parkinson disease, and this three-dimensional visual clue, whatever things I have put on the ground, after seeing that the exact mechanism is not known, but all the type of Parkinsonian feature you will see in this patient, that is shuffling, festination and freezing. And always see his leg, his flat foot strike instead of the heel on the ground. So this is typical Parkinsonian gait in this patient. Here he is having gait initiation problem whenever I told him to walk outside the room. Again, he take multiple steps. There is hesitation while turning and to restart the walking. But whenever he get three-dimensional visual clue, he will start walking properly. So in such patient who is having late onset Parkinson disease, sometimes you have to make a three-dimensional painting on your at your home on the ground, so that he can go to his bathroom. Sometimes laser stick people can use to get a visual clue and to improve their rehabilitation, because in late onset sometimes your levodopa carbidopa combination doesn't work in such patient. One interesting thing I found in such patient, if you try zolpidem, uh, it works very well those in those patient who is having improvement on three-dimensional visual clue. Now see this lady. This is another patient with Parkinsonian gait. Now she doesn't have any arm swing. She is having wide base, walk very slowly, and she is having mask-like face. If you see such patient, you have always have to look to the chin of the patient. Uh, this patient is having chin tremor. This is known as rabbit syndrome. Whenever you get such kind of history, always ask history of intake of any antipsychotic medication, or you should ask whether you are taking any anti-emetic medications. Anti-emetic like levosulpride. Levosulpride is one of the most common cause of drug-induced Parkinson disease. If you stop the medication, patient will improve in 8 to 12 weeks. Now, this is genetically proven Friedreich's ataxia patient diagnosed by me. Now, see his gait. In Friedreich's, there is a peripheral neuropathy along with cerebellar gait. So, both the ataxia. He is having clumsy, staggering, unsteady, irregular lurching, titubating, wide base gait. So, he is unsteady, uncoordinated, wide base, and his feet are thrown here and there. Whenever you find such patient, you should always suspect both cerebellar as well as sensory ataxia. Here the heel strike first, and he is having double tap sound. See, he is lifting his leg very much high, but whenever you see the heel strike first. So this is known as whenever you find sensory ataxia patient where heel strike first, that will indicate sensory ataxia. But whenever you find your toe striking first, that is equinus gait. That is predominantly seen in peripheral disorder only, but in foot drop patients that I will show you later. Now see this girl. First, I am sharing her eye movements. Whenever you get a young girl or young patient, young children with acute onset ataxia, always have a look on eye movements.
लेफ्ट साइड में देखो बेटा इधर इधर देखो
She is having ocular flutter. She had a history of 4 to 5 days of fever and followed by this ataxia.
अकेले चलो
Her MRI brain was absolutely normal. CSF was normal. So post-infectious cerebellitis was a clinical diagnosis. She is having wide base gait, ataxic. By giving just methylprednisolone, patient improved very much.
पीछे मुड़ो
So the clinical clue here is her eye movement disorder and her history. So we should always have a proper clinical history along with proper clinical examination to diagnose the patient. She absolutely improved with methylprednisolone. Now spastic ataxic gait. This video is from my residency days when I was in GB Pant Hospital. He was a very, I'm young boy presented with disability in working and I am having oscillopsia and difficulty in walking. It is very good for the resident doctor to diagnose the thing, but whenever you listen for the patient's disability, then sometimes it give a tear in your eyes. So for clinical examination point of view, at that time I have taken his video. You can see the downbeat nystagmus. Whenever you see right or left, you will get the downbeating nystagmus. So this is the clinical clue. A patient is having downbeat nystagmus, and this was his gait. This is typically jiggling or bobbing, tremulous, bouncing up and down body movements. His feet, he's throwing here and there. Now see the bouncing of the body. Whenever such patient you see, sometimes this patient came with you for the vertigo or imbalance while walking. Always look for the neck of the patient. He is having sprangle shoulder basically here. His left shoulder is higher side, right shoulder on the lower side, and he is having short neck. Whenever you see a such patient, always suspect CV junction anomaly. He is basically Kippel-Field syndrome, which gait ataxia. Now this is the treatable entity. Whenever in Indian scenario, most of the patients are vegetarian. So always ask, whenever you see any sensory ataxia patient, always ask for history of whether patient is vegetarian or non-vegetarian. Now this young boy presented with me with this. Here his base is slightly narrow. Whatever we get a description of sensory ataxia, but he is having, he is also having jiggling and bobbing gait. But when I asked him what was your whether you are vegetarian or non-vegetarian, he said he is absolutely vegetarian. Then I did further clinical examination. The simple clinical examination which is required, look for the reflexes of the patient. Whenever you see the ankle absent, whenever you see ankle absent and knee brisk and ataxic sensory ataxic gait, always suspect subacute combined degeneration of the cord. It is a treatable entity. The most common cause is B12 deficiency, and another most common cause is your copper deficiency. So his knee jerk is brisk, his ankle jerk is absent, he is ataxic. I will show his rhombuck. So he is having imbalance on rhombuck test. So basically, this is B12 deficiency with subacute combined degeneration of the cord. Injection B12 was given for 7 days regularly, and after that once a week for 10 more weeks, patient became absolutely normal. Now see this girl. She is having peripheral neuropathy. Etiology is same, B12 deficiency, ataxic gaze, sensory ataxia. Her rhombuck test is positive. Clinical clue lies in her examination of her hand. She is having knuckle pigmentation, very prominent knuckle pigmentation. So whenever you see suspect B12 deficiency, always have a look on look for the knuckle pigmentation. If knuckle pigmentation is there, then there is definite B12 deficiency. So these are the simple thing which we can treat with the simple medications. Her rhombuck stage is her rhombuck is positive, so she is definitely sensory ataxic. So nerve conduction study was showing sensory neuropathy in her case. Now see this lady. She is having bilateral foot drop. She is a known case of GBS, Guillain-Barré syndrome. She presented with the bilateral foot drop and wrist drop. When you see her walking, it is equinus gait. Equinus means her finger touches first instead of heel. Human being are a plantigrade, and horse and they are digitigrade basically. So whenever patient walk on the finger touches to the ground first, it is known as equinus gait. Here the double, this is also sensory ataxia. Here double tap sound of foot. Here the finger touches first and then the heel touches. In sensory ataxia, the Friedreich's ataxia patient I showed here, their heel touch first and then toe touches. Both are sensory ataxia, but etiologies are different. Now see this boy. First I will show how he stands from his sitting position. He climb on himself. He is having difficulty in walking since age of, he is presented to me at the age of 10, 11, and he is having this difficulty since last 4 to 5 years. Basically, this is known as Gower sign. Whenever you see such patient, you should always suspect, in young boy, you should always suspect Duchenne muscular dystrophy. If same kind of presentation or difficulty in walking you will get at age of 13, 14, then you can suspect Becker muscular dystrophy. And if same thing you suspect, you see in 20s or 30s, you should always look for the limb girdle muscular dystrophies. Now see how he is walking. This is known as typical waddling gait. Waddling occur because of hip abductor weakness bilaterally. So one hip goes up, down. So this is basically waddling gait. And there is exaggerated lumbar lordosis. This is because of hip flexor weakness. And patient walk with a wide base. Here the patient is having wide base. Generally in such patient, prominent calf hypertrophy we see. Here that is not that prominent, but his CPK level was 12,000. So this is typical waddling or lurching gait. Now this patient is related to ENT. This is one of the, sometimes you remember some patients for the life. This female has been labeled, seen by at least 10, 12 neurologists, 10, 12 orthopedician, and labeled she is non-treatable. Her brother was a lab technician, and once he brought her to me in this stage, in wheelchair. She is not able to walk absolutely. She is not able to do any activities at home. She is having tremendous pain in her both the lower limbs. She was labeled as limb girdle muscular dystrophy and labeled it as non-treatable entity. He just gave me few reports, blood reports, and one striking thing, that report is from 2014, and one striking thing I noticed in that report, her alkaline phosphatase was more than 1000, and that was a biggest clue. Then I have investigated her further, and these were the investigation. Her parathyroid hormone level was more than 1000. This is basically parathyroid adenoma. Her parathyroid glands were removed. After removal of her parathyroid gland, this was her gait. This is after 2 months. This is after 2 months of surgery in April 2020. I have diagnosed her in January 2000. After 2 to 3 months, she is having this kind of walking. This is also waddling gait, but here main problem is musculoskeletal problem. Basically, she is having. She walks very slowly with walker, and this is her latest. after 6 months of 7 months of surgery. This is also waddling, but sometimes single investigation, when a simple investigation can give you a clue. In her case, if I have not seen her alkaline phosphatase, I could not able to diagnose her. And after to treat such patients, sometimes it is very rewarding, and person can remember such patient for the life. So she is a parathyroid adenoma along with that. So whenever my take home message from this case is that whenever you find such patient who is having severe pain, at least do calcium, parathyroid hormone, and alkaline phosphatase level. If you get some clue, you can treat this patient, and that will be very much rewarding. Now I will go to hyperkinetic gait disorder, that is dystonia. Whenever you find such young boy with this kind of dystonia, he is having hand dystonia.
हात पुढे कर दादा.
Now see how he is walking. He is having dystonic foot. He is walking on his toes. Whenever young boy with some dystonia, whenever he comes, always do
जा जा चालत.
one clinical examination when young patient came to you with dystonic posturing. Always look for one investigation, that is eyes. You have to look for KF ring. He is a Wilson disease. It is a treatable entity. Whenever you see young patient with dystonia, always have examination of the eyes, and if you find KF ring, then you can treat it as a Wilson because it is a treatable entity. This is rare, but I think one should know this entity. See how she is walking. She is walking on the edges of her foot. Now backward walking is quite comfortable, but the forward walking is difficult. Backward walking was quite comfortable, but the forward walking was difficult. In such patient who is having only foot dystonia, one should ask for the history of diurnal variation. She complaining of this walking difficulty only in the evening time. Whenever you find such patient with foot dystonic posturing, only evening time or as the day passes, if your patient get more and more difficulty, you should always suspect dopa responsive dystonia. She is absolutely fine with a single tablet of levodopa carbidopa combination. Now at the evening time, after 2 to 3 days I call her, she is absolutely fine. This is autosomal recessive disorder basically, but it is absolutely treatable. Till this age, after it was started at the age of 5 to 6 years, and till the age of 13 14 she was walking like this in the evening time, but history give you a diagnosis. And backward walking, whatever I told initially, that is very useful in dopa responsive dystonia. Those patients walk backward very well compared to the forward. Now this, see this young boy, he is having right torticollis. He is also having dystonia. This dystonia occur at the evening time. See his hand. His hand is completely placed on his thighs. He is having torticollis. His neck is turned towards the right side. Backward walking is better. cervical, here the cervical dystonia along with the foot dystonia, both are present together. But cervical dystonia is very rare manifestation of dopa responsive dystonia. In this boy also, I have given a trial of syndopa and see how he is absolutely fine. Her mother is also having dopa responsive dystonia. This is the family basically. This boy and his mother, two patients I have described, but mother is having Parkinsonian feature more compared to the dopa responsive feature. He was also fine on single tablet of syndopa.
सिंडप्पा गोळी दिल्यानं काय वाटलं?
छान वाटलं, म्हणजे बरं वाटलं, बोलता पण आलं आणि म्हणजे त्रास पण कमी झाला, मान पण थोडी बरी.
संध्याकाळची जी मान वाकडी व्हायची ती काल संध्याकाळी झाली होती का?
नाही, ती बरी झाली, पण इथं थोडी नस हे दुखत होती.
बरी झाली म्हणजे वाकडी होत नाही आता.
वाकडी नाही झाली.
So his neck movements and everything is absolutely improved. This was his disability, cervical dystonia, foot dystonia, everything. And this is the last slide. This is also choreiform movement disorder with hyperkinetic gait.
हे झालं.
फिर पाठ. He is having left-sided chorea. Whenever hemichorea or patients came at a young age, always suspect Sydenham's chorea. It is a treatable entity. We have to investigate in terms of ASO and CRP titer. Short course of steroid and cardiac workup is needed in such patient. It is a treatable entity. If you give small dose of valproate or haloperidol, patient's chorea will improve absolutely. So whatever, these are the prototypes of various gait disorder. I have picked up only those who, although they were, some of them were rare, but these are the treatable entities, and one should look for the treatable entities while looking for the gait disorder. And this one is the last one, that is gait apraxia. Now see his examination whenever he is in the bed.
Cycle.
Always ask whenever you suspect normal pressure hydrocephalus or some particle dysfunction with disorder.
पाय सरळ करा.
Always ask patient to cycle
दोन्ही हात वरती घ्या.
in the bed.
वरती,
If he is
वरती.
able to do cycling absolutely normally in the
खाली
bed,
करा.
that
करा
means
वरती.
he is not having any limb weakness. But whenever you ask to them to walk, at that time their feet is like a glued to the ground. And this is known as magnetic gait, or sometimes neurologists call it as a gait apraxia. So I will end with this quote of Albert Einstein: information is not a knowledge. The only source of knowledge is the experience, and you need experience to get the wisdom. Thank you.
A big thank you, Goge sir. And you actually meant when you said that talking does the talk will do the talking. It was excellent, and we have been getting messages after messages telling us this is one of the best talk in this subject people have listened to. So thank you very much.
Thank you, sir.
Without much waiting, we'll is to be delivered by Dr. Henry from Shillong. So I'll just give a brief introduction of Dr. Henry. Dr. Henry completed his MS and MBBS and MS from Wardha Institute of Medical, Mahatma Gandhi Institute of Medical Sciences, Wardha, and did his fellowship in head and neck oncology in 2008-2009 from AIIMS, New Delhi. At present, working as a ENT consultant in Nazareth Hospital, Shillong, Meghalaya. He developed a keen interest in neurology and has been actively participating in workshops, including the one he himself had organized in 2010, where Dr. Srinivas was one of the faculties. He had done it with Dr. Julfikar. It was, I think, in 2017. But those who know him well, like me, Dr. Srinivas, know him also for something very different, and that is his adventurism and his nature photography. He is one of the best nature photographer, and of course, his long biking trips are legendary. Dr. Henry, over to you, sir.
Good evening, everybody, and thank you, Gautam sir and Dr. Surajit, Dr. Srinivas, for all the encouragement that you've been giving, and of course for this opportunity. So I'll share my screen. The topic which has been given to me to speak on this webinar is on vestibular compensation and vestibular rehabilitation. So there's been a tremendous or a treat of knowledge in the past 2 days, and I hope I can deliver something which will be beneficial for all. So we have drugs, and so many drugs have been developed and introduced in the treatment of a wide range of diseases causing vertigo. Yet rehabilitation seems supposed to be the most effective tool in the treatment of vertigo. As we all know about the Cawthorne Coxey exercises. So what happened is that in the mid 1940s, Sir Terence Cawthorne, an otolaryngologist, he noticed that his patients were recovering much faster when he had subjected them to performing them rapid head movements. So he and Mr. Cooksey, a physiotherapist, they went on to formulate exercises for the management of vertigo, which we all use to this day. Okay, so what they conceptualize in these exercises based on habituation and sensory substitution, which I will come to it later in the topic. But it's seen that over the years that these concepts were not sufficient enough to explain the therapeutic effect of vestibular rehabilitation. So symptomatically, vertigo or dizziness, they're mostly about conscious symptoms, and they related to the consciousness of the disequilibrium, the balance disorder caused by the presence of nystagmus. Therefore, the rehabilitation is also aimed at resolution of the objective disorder, and also at the subjective to resolve the subjective consciousness. You see, the problem all begins with we. You know, it's just like, you know, if you watch the what the kids watch these days, the cartoon show. You know, there's a very cute word which is stupid papa, huh? You know, stupid papa. So, you know, it's not like that. We human beings have gone to evolve into from a quadrupedalism to bipedalism, and we tend to use our feet more than any other two-legged animals. We use for locomotion, jumping, running, hopping, and everything. So being into this bipedal creature, we are always an inch or two from falling. We're always at the verge of falling. So come on, before we go into the plan for rehabilitation, it is customary for us to have a detailed treatment diagnosis. So we should have a proper treatment diagnosis where both the physiotherapist and the treating physician are well aware of all the clinical signs which can be elicited from the patient. Not to say that, firstly, the case history, which forms the basic or the key to a correct medical diagnosis. And then the examination of the eye, which involve the saccadic eye movement, the pendular eye tracking, looking at the vestibulo-ocular reflexes, all the examination of these, they give you the basic of how, when, or at what level to start your rehabilitation. But we should not forget to look at the postures, which just now Chogesa had shown so beautifully in the presentation, about the posture and about the stance. So once you look at these, you know that which you can go and which you need to refer to a neurologist for a better assessment, for a complete assessment and better handling of these cases. And we should, as a physiotherapist, you should see, because posture is in a way, it's a protective mechanism, you know, so it shows as being a protective mechanism. It can lead to the cause, so it can help the physiotherapist on correcting the postures, doing maneuvers to correct the postures, giving exercises to correct the postures, knowing the stance, you know, by examining the Rombergs and examining which kind of strategies is using for maintaining the balance, whether he's using the ankle strategy or the hip strategy for maintaining the balance. Then you ought to know the way how the head and the neck, they interact with each other to maintain balance. And of course, again, the gait, the examination of the gait, which the presentation just now was beautifully elaborated. And at the end, we should forget to assess the cognitive function, because that also is very important. So the person should be able to perceive his own body geometry, his alignment to an environment, his alignment with the environment, or his response to the environment, and the way he navigates around, and his ability to do dual tasking or multiple tasking. Now we have heard that all that vestibular lesion, okay, this disease and that disease, and we wait for compensation, and this drug affect that compensation. What exactly is this compensation? What happens in this compensation? We rarely talk what exactly happened, and we don't go too much deep in what exactly happened. So let me try to brief in what little knowledge I have about vestibular compensation. It's just like, you know, when you type a word in if you do you make a mistake in your Microsoft Words or Google, you know, there's an autocorrection. So there in the body also we have an innate or an inborn mechanism to correct. So if there's a defect somewhere, so the body always tends to correct itself. So that is what compensation really means. And with the aim that that whenever there's a lesion, whenever there's a vestibular lesion, the aim of this compensation is mainly to stabilize the head and to stabilize your vision. That's the crux of the whole balance. Now, this concept of compensation evolves around the concept which is important in like another other field as well, and that is the neuroplasticity. And here in vestibular compensation, there are two modes in which this neuroplasticity happens. That is central compensation, and at the same time, the restoration of the peripheral vestibular function. Though neural plasticity has not been completely understood, but various experiments have shown that there are parallel neuroplasticity which happen at various sites in the brain. And these activities, these phenomena that happen, they include the change in sensitivity of these neurons, the vestibular neuron, to the inhibitory neurotransmitters, the excitability, the change in the excitability of these vestibular neurons, the way the cerebellum controls the brainstem. Then there are glysis which occurs, neurogenesis which happens, and most importantly is the reorganization. It is just like, you know, we all have experiences when we go to a government office and we compare that to a corporate or private office. You know what happened in the government office? If there's one clerk who's absent, you try to take a file or a letter, that letter is not going to pass. So it's not going to work, you know, because we in a balance system, we need something which, if something goes wrong now, immediately the next step, somebody has to do. So it's just like in the corporate system, you know, somebody takes a leave, so immediately somebody take over. There's a complete reorganization of the system. So here also there's a complete reorganization of the synaptic network to keep the work going. As we go to the vestibular compensations, it's also good for us to be acquainted or to be familiarized with few terms which are involved in the phenomena of vestibular compensation. One is restitution. Restitution means a complete repair of the lesion. Adaptation. The adaptation is a phase where one adapts himself to the changes to the extent that he doesn't feel any odd feeling anymore. Like now you have a like we talk about BPPB, adaptability. You repeat the procedure at one time. When you do, you feel severely giddy, and you keep on repeating. You don't feel that giddiness anymore. So that's adaptation. Okay, then the next terminology is habituation. Now, what's habituation? Habituation is more of a central mechanism. Now here, what the body does is tends to reduce the intensity and the duration of the vestibular reaction. This happens by changing the way the vestibular ocular reflex occurs, response to a stimulus, and over time, this persistence of this modified uh, vestibular ocular reflex occurs, and it persists. These modification persists till the person becomes habituated to these pathological changes, and he does not feel the effect of the lesion anymore. And the last terminology is compensation. Now, what happened compensation? When you say compensation, it means that the primary lesion exists. It continues to persist. It's not that the lesion has ceased to exist or it's healed or nothing, but the primary lesion may continue to exist. But now, when you have a problem in the vestibule, the body uses another sensory organs like the vision or the proprioceptive to overcome the weakness of one. So it's a taking over. Sensory is a sensory substitution, substituting the failure of one. Suppose if you have vision is bad, it is not working for your balance, the vestibular and the proprioception, they get exaggerated. Now, if your proprioception doesn't work at the cervical level, then your hip, your knee, your ankle, they take over, and it's compensated by the vision or the vestibular. So these are organization that changes. So there's a complete reorganization of the reflexes, and at the same time there are also formation of a complex circuits which develop, and these all develop just to improve or to restore the function. So vestibular compensation ideally occurs in three phases. So the first phase in which vestibular compensation is adaptation. Now adaptation is basically what I've shown in the previous slide. That is the sensorial substitution. Okay, so the sensory loss of one part is substituted by another sensory organs. Once that adaptation occurs, one enters into the second phase of compensation, that is the habituation. So habituation is like there's a change in the neuronal mechanism. Now what happens is just like now we do a VNG. We calibrate the system, and then we perform like a rapid head neck movement, and then we perform some other exercise, the test, and then we want to perform a pendular tracking test. But you'll notice that the camera has changed. The tracking your previous calibration has changed. So when you're doing the tracking, you don't get, it doesn't follow, the eye and the head and the eye movement and the target, they don't calibrate, they don't meet each other. So what happens that we need to recalibrate the system again and then perform the test. So exactly in the same manner here, when you have a problem, the nervous system undergoes a recalibration, or they completely modify the whole calibration in order to achieve a more balanced or a correction of the balance disorder. Now, once they have achieved adaptation and habituation, when these sensory habituation has occurred, and when the calibration has occurred, one enters into the last phase of vestibular compensation. And this is a phase where there is a complete revamp of the system and reorganization of the entire mechanism, from reflexes, from responses, from the synaptic networking, and how to react to a stimulus. All these, there's a reorganization, the entire balance control, with the main aim is to achieve the ultimate goal, that is to have a equilibrium. Okay, now the question which comes up now is, a disease has occurred, compensation started. Okay, so when does it start? When does it when it ends? Does compensation occurs to everyone, and to what level, and what happens to those who don't compensate? So the answer is that compensation begins immediately after the lesion has occurred. Fortunately, most of our patients, they compensate very well. But unfortunately, for a few, the compensation happens very poorly. And it is for these class of patients that we subject them to therapy, which we call a vestibular rehabilitation. Now, vestibular rehabilitation is a slightly different kind of rehabilitation. It's a specialized kind of rehabilitation where it is mainly targeted at correcting your movement intolerance, your imbalances, and all. So it's generally indicated in a poorly compensated vestibular lesion, and it's mandatory that you have a confirmed diagnosis that it's a vestibular pathology, because there are various other non-vestibular pathology which will cause the similar imbalance or vertiginous symptoms. Okay, so it will but to initiate a vestibular therapy, we need to have a confirmed diagnosis of vestibular pathology. Regardless of age, the duration of intensity, anybody can be subjected to can be placed into this protocol of vestibular rehabilitation. Now, prior to having to subjecting a person to vestibular rehabilitation, it is mandatory that we have a proper counseling. So you have a proper counseling. The person who is supposed to undergo this rehabilitation should know the problem, the extent to which the problem will persist, and what are the possibilities, what are treatment possibilities, what are the outcome. He should also understand that once he gets into the protocol, he should be regular. So we can, the physician and the physiotherapist should have a proper pre-treatment assessment. The reason is that you can customize the therapy for each individual. There is also a need for a continuous reassessment, say every week or 2 weeks. And one should also understand that that these sessions will require home management, home therapies, and also hospital-based therapeutic protocol. Now, what is the goal we want to achieve by vestibular rehabilitation? It's mainly we want to have a gaze and your posture stability. So these are the two main goal you want to achieve, and also to avoid severe attacks of vertigo, and if possible to avoid vertigo at all, and also to enhance the person to go back to his normal daily life. We have all heard of the coxycoton exercises. We all know, we all are practicing it till to this date. But I have come across a different kind of a model. It's the basis is the same practically. Okay, it's just that a name is given, a model is given, just to understand better. So you understand better how to plan your rehabilitation. So this is called the MCS model, which has been prescribed by Alpini, Cicerni, and Bugononi. So they have published a book on this. So this MCS model is M stands for mechanics, cybernetics, and synergetics. So let's see a lesion. A lesion has occurred in the vestibular lesion. So what does a lesion cause? It causes an impairment. And that impairment, if not treated, not managed properly, can lead to disability. And this disability is the behavioral changes, which in the first talk, which Dr. Zulfi had mentioned, the disability like the triple PD, which is caused because of some other lesion in the vestibule. So now the three phases of vestibular rehabilitation, we divide them to three phases. One's a mechanic phase. The mechanic phase symbolizes the lesion. Okay, what is the mechanic phase? It's the failure of the workers, skilled workers. Now, who are these skilled workers in the balance system? They are generally the reflexes, the muscles, and the joints, right? Okay. Then the second phase is the cybernetic phase that symbolizes the impairment. Now, cybernetic phase means literally cybernetic means that there's a failure of the communication. So there's a failure of communication of the components of the balance, meaning that the muscle, the proprioception doesn't communicate well with your eyes don't communicate with your spine, they don't communicate with each other. So that's the second phase, correct that. Then the third phase is a synergetic phase, or which symbolizes a disability. Now, this synergetic phase literally means, synergetic means working together. So in this phase means the system, the component, they don't work together. They can communicate, but they don't cooperate with each other. So what is the aim of a treatment is that we don't want a patient to go into the impairment phase stage or to the disability stage. We want to stop the problem at the lesion phase, okay, at the mechanical phase. We don't want it to progress. You know, if they progress into this phase, which eventually they with a lot do, it lengthens the physiotherapy, okay, the therapy. It becomes a prolonged therapy. So what's the first phase? Mechanic phase. As I told you, this is the management of the skilled worker. So here, what is the basic of this? What basically you do in the first phase, this mechanic phase, is that we try to restore or enhance the reflexes, okay, the reflexes, and we enforce the extensor muscles, and at the same time, by doing so, we prepare these patients for the next phase. It's a more complex phase. That's the cybernetic phase. We prepare them for that. So what do we start with in this phase? We start with very simple exercises, like the simple breathing exercise, relaxation exercise, so that they relax, okay? And then you start with exercises which deals with ocular reflexes, okay, with the spinal reflexes, with exercise which deals with the mobility of your hip, your knee, your ankle, your shoulder. So simple movements, all these, okay? This is how we're going to start with. And once they are able to do these exercises properly, then we progress to the next phase. That is the cybernetic phase. The cybernetic phase. Now, what is the cybernetic phase? In this phase, we try to restore the communication between the different components of balance, with the aim that the person should be able to achieve a correct posture. So now, to simplify, the first phase, you try to correct the reflexes, okay? And in the second phase, you try to correct posture, okay? So first phase, you deal with reflexes. The second phase, once the reflexes have gradually, the patient able to do these reflexes exercises, you progress him to him or her to the next phase, that is correcting posture. Now, how do you do this? By trying to incorporate more complex exercises, so that the person can balance himself more better. He can have more better postural adjustment, more motor reaction to maintain a better balance. Subject them to exercises which deals with static and dynamic balance. You know, the where he will try to achieve balance in a static state or in a dynamic stage, and exercises where he or she will be able to fixate the vision and the head during movement. So they practically involve the interaction of the ocular and the spinal reflexes. Now, only and only if your patient are able to do the first two phases, then only we can progress to the third phase, that is a synergetic phase. Now, synergetic phase is more complex phase, okay? Here, because you are going to deal with the cognitive aspect of balance. So you're going to have them combine all the components together and get them the component to cooperate with each other, so that the person can have an orientation of himself to the environment. Okay, he can respond to the environment. So that is the aim of this, the third phase. So the more complex and tougher exercises here. He will need an extreme coordination of the head, body, the eye. Okay, so they're more complex, more tougher. So the aim of this is to reduce incoordination, disorientation, and here they will do so by learning new movement strategies, okay, and the correct way to orient themselves. So these are few exercises that we all know that, the coxycoton exercises. So where you have the head neck movement, okay, and the exercises in the sitting position, the exercises in the standing position, in walking. But what I'm going to illustrate a few in the next few slides, a few other exercises. They're basically the same line, okay, but they're just an addition of exercises where you perform in the same in the supine position, on a sitting position, and on a standing, and also moving. It's very similar, but only the difference that in these exercises, which again these exercises are described by Alpini in his book, but these exercises are more interactive. They are more dynamic. Unlike, say, for example, we in the coxycoton exercise, what we ask a person to look right, look left, look up, look down, okay, and rotate your head and all like that, okay. But here, for example, this is an example. So they ask you to fix it on an object in front, on the side, and you try to fix it. Look left, fix on the orient, shift leg, look at the object. So these are more dynamic, more interactive. These exercises are more interactive, and they involve here more exercises which will help in enhancing the reflexes, the knee reflexes, your ankle reflexes, your paraspinal proprioceptors, okay, the shoulder joints. So all these exercises are incorporated here. The vision, like you like, for example, like lying down, okay, and then you get up and you fixate your eyes on an object in the ceiling, and as you get up you fixate on another object in front of you. So these are, as I'm telling you, that these exercises which are prescribed by Alpini, they are more interactive and they're more dynamic, okay, they're more dynamic. But at the same time, one should understand that that these are mostly home-based exercises, okay, but a few of these exercises cannot be done at home because they need an assistance of the therapist or under supervision of therapist. They are more tougher exercises, okay, and then so they will need to come to the hospital. So they should have a session of at least twice a week, and then the rest exercises can do it on a home-based. So like the example where you need the assistance of a therapist is like the stance, okay, and then the therapist will push and see how he maintains the balance, how he uses muscles to maintain balance, push on the side, push on the back, okay, make him sit on the bed edge of the bed and push from the sides, or twist his leg. So these are few exercises which has to be done under the guidance of a therapist. Now there are also instrumental rehabilitation which have been mentioned, but these instruments are very, very expensive and they're not easily available. But of course, in all the hospitals who have a physiotherapy unit will have a TENS. I have not used it. I've used only once, and it does look promising. And what it says that the TENS, which actually the TENS we use it in TENS, that means a transcutaneous electric nerve stimulation, which actually is being used in the physiotherapy unit as for pain relief, especially in ortho cases or other trauma cases. But here, if you use it at the frequency around 80 hertz, okay, when you use these stimulations using TENS, they tend to improve your vestibulospinal reflexes and enhance your visual spatial abilities and cognitive function. That's what they have shown. And they do so by acting on a lot of these muscle spindles. You know, the neck, the deep muscles of the neck, they have a lot of muscle spindles which are involved in the various reflexes, and they also help in exciting the peripheral nerve. So again, we can once they have gone again and are finished, completed the first two phases, the mechanic phase with the reflexes and the cybernetic, which is the posture phase, then you can again subject them to various sports, you know, like badminton, table tennis, where you need to coordinate, coordinate all the movements, eyes, the spine, the joints, all the movements. So these, like, you can ask them to play badminton, table tennis, or yoga and tai chi have been prescribed to. Okay, now to summarize, Physiotherapy, vestibular rehabilitation has to be customized. Start it as early as possible because you want to stop it at the lesion phase. You don't want them to have an impairment, which might go into a phase of disability, which becomes more tougher to rehabilitate them. Have a proper counseling and always involve a family member because they are the one who will be at home. They will be the one who are going to support them in all the activities. And most important is give them assurance that they're going to be all right and they're going to recover and they're going to come back to normal life as before. So most of the topic or the illustration I've taken is from this book by Alpini, Cesarni, and Brognoni. Okay, it's a wonderful book. We try to get it. It's a very useful book. And I hope that at the end of this COVID era, we'll see a lot of you in Meghalaya. It's a beautiful place. So we hope to meet you there. Okay, thank you. Yeah, over to Surjit.
Hello. Excellent, Dr. Henry. And for the audience's information, all these photographs are Henry's, obviously, the great photographer that he is.
Oh, thank you.
All the snaps that he had put in the last advertising Meghalaya. You don't have to advertise really. We are only just waiting for this pandemic to go up. Mohan sir has rejoined. Sir, if it is, would you stop share?
Yeah, I'm trying to search. I've lost the.
Just on top. It's just on top.
Yeah. I got it. Yeah. Okay, yes.
Mohan sir, actually, sir, there's one more talk. I will take your questions.
Yeah, no problem. Anytime. I'm here now. I just had some. I had to just see somebody face and came back. I'm free now. No problem. Go ahead to the talk.
Then come to your questions, sir.
Yeah. I'll wait. I'll listen to the talk. Yes.
Okay.
Thank you.
Then, thank you, sir.
Yeah.
Sorry. So we'll straight away go to the next talk to be delivered by Dr. Sarubhat Jagtap, sir. So before starting the talk, a small introduction of Sarubhat, sir, who actually it's not needed, but we'll just, for the sake of it, Sarubhat, sir completed his postgraduate and MBBS course from BJ Medical College, Pune, and is at presently attached as a consultant ENT surgeon and vertigo and deafness specialist with Jagtap Hospital, Dhule. He is a pioneer of the state-of-the-art neurology center at Jagtap Hospital with all the modern investigation and modalities, and has been an associate professor of SBH Government Medical College, Dhule. He has numerous presentations and has been a guest faculty in numerous conferences, and most of all, he has been there to hold hands to a lot of newcomers who initially started in this practice, like me. 10, 15 years ago, he was always there. Today, he's always there. So back up to you, sir. Sarva, sir, I think you're muted. Please unmute yourself, sir.
Right now. Can you see me? Is my...
Yes, we can see your slides. We can
see your slides, sir.
Okay, that's great. A very good evening to all of you, all the seniors in the panel, all my fellow colleagues who have been making wonderful presentations for the last 3 days. It's a big opportunity for me, and I thank Srinivas and for having me on this panel. What has been happening in the last 3 days is we started with the basics, and now we are at the last and the final presentation of this masterclass. The topic that has been given to me is the way out. Well, probably it means what I have to present is how, as clinicians, how, as practitioners, we have to find a way out when we have a patient of vertigo in our presence. We have seen wonderful presentations, and then let's see how we can incorporate all this information in my presentation. As a clinician from any faculty of medicine, maybe from the modern medicine, maybe from the Ayurvedic medicine, maybe from the homeopathic, maybe the Unani, or all sorts of practitioners, we all get to see patients who will of acute vertigo, but then the individual has been having vertigo in the past. Let's go through the situation A. Well, the patient is presenting with you with the first episode of vertigo. The patient has vertigo. He tells you there is a severe spinning sensation for the last so many hours. The patient is experiencing nausea and vomiting. The patient is sweating. The patient is frightened, and so are the relatives who are accompanying him. Well, this can be a classical case of acute vestibular syndrome. On day 1, we saw Dr. Pratik, and on day 2, we saw Dr. Vishal, giving us ample of information about the hints test. And then how do we go about when a patient of acute vestibular syndrome is presenting to us? When a patient enters my chamber, or if I am called to the casualty, as a clinician, I will ask the patient either sit comfortably if the patient can, or ask the patient to lie down. Simultaneously, ask for the history. If the patient is giving you all the history that is essential, well and good. Otherwise, the relatives who are accompanying will start giving you all the history as to when the event started, how long has been he experiencing the vertigo, is it a 2 rotatory vertigo, is he experiencing nausea and vomiting, for how long, did he have any fever, does he have any upper respiratory sort of infection, along with did he, all these things matter a lot when we are asking the history. And by the time we are talking with the patient and the relatives, either we have some assistant with us who will be assessing the vital parameters like pulse, BP, how conscious the patient is, and then we get a glimpse into his eyes and start looking for nystagmus. We can assess the gait of the patient as the patient starts walking into the chamber. A quick look at the cranial nerve function is also warranted. Again, we reiterate the hints plus, and all the examinations which will help us making a diagnosis, whether it's a peripheral or a central cause, have to be done. They are very, very, very important. Any doubt of central cause, we should immediately seek urgent neurological opinion. Well, the neurologist has seen the patient and then the patient is still with you. then how do we go about? Naturally, I would always want that the patient should be hospitalized. Recently on YouTube, I saw a clinician making a presentation of an ethical dilemma. What was his dilemma? There was a patient who was in the 50s or 60s who came with nausea, vomiting, had vertigo, everything. And then he kept on feeling that this is a peripheral or a vestibular neuritis or a peripheral vestibulopathy. But then he felt, why should I be hospitalizing a patient with a peripheral cause? I feel if the patient is hospitalized, we can always monitor if there is any symptom which is of any grievous cognizance which we need to take. We need to start IV fluids if the patient has been vomiting and the blood pressure has gone down or the patient is feeling dehydrated. Naturally, we have a situation where we need to give some injectable antiemetic, which is also a vestibular sedative, so that both of them can be taken care of. Yes, we all are aware and we all are familiar with this molecule, that is fluoroperazine. Generally, we know this in the name of Stemetil or Acuvert and so many other names. The dose which we need to give is according to the body weight, the age of the patient, and accordingly, but generally 1 ml, that is 12.5 milligrams, is generally given. We will observe how this drug helps. In the earlier days of my practice, we had access to injection dimenhydrinate. I'm not sure whether this is available today. If it is available, I would definitely prefer it over the prochlorperazine. This patient who walks in is with fear, anxiety. I don't know how many of us or how many of the delegates must have themselves experienced an episode of vertigo. It's really terrible. It's really fearful. So this fright really needs to be taken care of when the patient is with us, and allaying the anxiety becomes of prime importance. If the patient is tolerating oral medicine, we can give him zolpidem, clonazepam, or oral diazepam. Now, if we are suspecting vestibular neuritis after having done the clinical examination, and if you have the equipment with you, like a video Frenzel's or a video Frenzel's glasses or a video Frenzel's examination goggles, we can do some preliminary test if the patient is allowing, and then we can easily come to a preliminary conclusion if the patient is having a vestibular neuritis. And if it is so, naturally steroids would be more helpful in such a patient. I would prefer to give injection dexamethasone 8 milligrams stat. Why? Yes, it will help if the patient has got a viral infection or some inflammation in the vestibule. That will also be taken care of, and dexamethasone also has got a very good antiemetic activity. I would keep a watch on how the vital parameters are, and once the vomiting subsides, I would continue the drug which will take care of the vertigo, that is a vestibular sedative. And for me, the drug of choice is generally dimenhydrinate, which is given in 50 milligrams. I have written maximum 3 days, but then I would prefer to tell the patient, if you are free of vertigo, stop the medicine. If dimenhydrinate is not available, I would still prefer giving prochlorperazine, maybe for a day or two. And then if the patient responds very well, I would immediately ask him to stop. There's no reason why he should continue that. And I would prefer not to add any other drug along with this. In the past, some time ago, it would be aimed at controlling the symptoms, vertigo, nausea, vomiting, and associated symptoms, depending on the diagnosis. So if the diagnosis has been reached in the past and somebody has seen the patient in the past, naturally we'll have that diagnosis and we can take it ahead from there after managing the acute stage. All over the world, we have so many neurotology clinics which keep on diagnosing patients and then starting treatment. Of all the patients, like if you have 100 patients, we have 81% of the patients with the diagnosis coming with vestibular migraine, benign paroxysmal positional vertigo, Meniere's disease, and vestibular neuritis. Apart from this, we have triple PD, central vertigo, bilateral vestibulopathy, vestibular paroxysmia, perilimb fistula, and unknown vertigo syndromes. This gives us as clinicians a clear idea. We have to be very thorough in assessing the top four. The top four mean the migraine, BPPV, Meniere's disease, and vestibular neuritis. We have just had a fantastic presentation by Dr. Surji on vestibular migraine. Where he dealt with all the aspects of vestibular migraine. There will be some sort of a revision when I'm brushing with all the topics as I go ahead. We have a place, we have to think about management of acute episode and prevention of recurrent episodes. How do we manage acute episode in the case of vestibular migraine? Naturally, we have a plethora of drugs available like prochlorperazine, dimenhydrinate, Cenarizine plus dimenhydrinate. This is a new combination which is available right now, meclizine and promethazine. According to the studies which are available and which have been done over the last few years, this combination of Cenarizine plus dimenhydrinate does help the patient take care of the symptoms reasonably well and very fast. If associated with headaches, we are left with many alternatives. Depending on the age, depending on the severity of the headache, we have to make a choice between the triptans, the analgesics, and then the antiemetics. The drug of choice for me, if the age permits, would be sumatriptan, and I believe naproxen is a very good analgesic that takes care of the migraine headaches. Along with that, if the severity is less, I would prefer paracetamol and domperidone. We need to prevent attacks of vestibular migraine, which is of prime importance. Now that we have diagnosed it, we have been given all the criteria of diagnosis by Dr. Surajit. We need to follow that and come to a diagnosis. Well, he has amply explained how dietary restrictions are helpful in migraine because these are all triggers and they need to be taken care of. We have to avoid cheese, chocolates, Chinese and curries. Nowadays, MSG is being addressed in print as E621 because people have come to know MSG, monosodium glutamate, is something which they need to avoid. Regular sleep, yes. Meals and exercise make a lot of sense. I have come across a neurologist friend of mine who is like he's asking all his patients meditation, which makes a huge difference in prophylaxis of migraine. And I have a few patients of mine who are doing very well with meditation and needing less and less drugs. Again, we come to the triggers which we need to avoid, and then we have all the triggers like processed food, alcohol, chocolates, lights, and so many other things. Prophylaxis can be effectively managed in patients of vestibular migraine. And we have drugs like beta blockers, calcium channel blockers, antidepressants, anticonvulsants. Patients in whom there are more than one episode per month are definitely in for some prophylaxis because that will prevent migraines, headaches, and migraines, vertigo. If you prefer propranolol, that can be started with the doses of 10 to 20 milligrams as low, and then you can go on increasing. Nowadays, you get sustained release propranolols. We have flunarizine, which can be given in the doses of 5 to 10 milligrams per day, that too according to the weight of the person. If there is a person because there is a chance if flunarizine, if given for a long period of time, maybe for 2 months, 3 months, 4 months, 6 months, that is how we titrate the doses in case of migraine. Flunarizine tends to put on, the patient tends to put on weight. So naturally we'll have to give a thought to this when we start flunarizine. Nowadays also we have combinations of propranolol with flunarizine available. Amitriptyline is a drug which really helps if the patient of migraine has got associated depression. Maybe we start in the minimum of the doses to be preferably given at the night time, 10 milligrams, and then we can go on increasing. Topiramate is a good anticonvulsant, which is very good for me as a prophylaxis agent. And I generally prefer my patients to be on topiramate because they tolerate it very well. And I generally start with 25 milligrams at the bedtime and go on increasing maybe in the next week or 15 days time. So that is how prophylaxis can be titrated and we can have patients free of migrainous headaches. Along with this, physiotherapy has a big role. There are patients who have got head and visual motion intolerance and they need to be rehabilitated. We just had a fantastic presentation by Dr. Henry when he explained how compensation and rehabilitation are the key to the success of rehabilitating a patient of vestibulopathy. The psychological element in a patient of migraine definitely needs to take care of. In chronic patients who have been suffering for years together, maybe 2, 3, 4 years, it may lead to a migraine anxiety related dizziness, where I prefer to have a help of a psychiatrist to treat the anxiety and depression. Other drugs which are of help and has been proven of help of late are riboflavin, magnesium, vitamin D, and coenzyme Q10. I have been using all of these. Vitamin D in particular, a large study of migraine has been shown with 40% of migraine sufferers having a deficiency of vitamin D3. Meniere's disease was dealt in great depth by Dr. Rohiwal yesterday. Well, we again have an acute stage where a patient presents like a patient who has got an acute vestibular syndrome. He has profuse vomiting, nausea, severe spinning sensation, and then sweating and other vegetative symptoms. I recollect it is such a bad presentation at sometimes. A patient of mine who was a bank manager forgot to tell his assistant he is a patient of Meniere's, and he was regularly following up with me. One fine day in the afternoon when he was in the office and there were a few gentlemen sitting across, he started feeling dizzy, started vomiting, and started sweating. In spite of this guy telling the colleagues, guys, I have got a Meniere's problem, you just call up my doctor who treats me for Meniere's, he will tell me what to do. The guys called an ambulance, took him to an ICU. So this is a scenario which can be of panic, and it can create a panic in the relatives and the friends who are around when a patient is suffering from in the acute stage of Meniere's. We have drugs like prochlorperazine, dimenhydrinate, domperidone, metoclopramide, again the combination of cinnarizine and dimenhydrinate and triflupromazine. If the patient tolerates well, I would still prefer giving a single drug called dimenhydrinate because it works very well and it prevents the chances of developing extra yesterday about how to diagnose or confirm diagnosis of Meniere's disease. We were sure about having 3 things: glycerol test. The second thing which we wanted was the MRI with gadolinium. and the third thing was ECOG. So if all these things fall in place, and if we have a confirmed case of Meniere's, if the glycerol test is positive, I would definitely like my patients to be on acetazolamide, because the glycerol positive indicates the patient will have some benefit with diuretics. We have drugs which can be used like acetazolamide, hydrochlorothiazide, and a combination with triamterene. For me, the best drugs is still acetazolamide, but then said and done, these drugs will have some problems when we administer these drugs, and we'll have to keep a watch on the electrolyte levels and the other symptoms which are associated with this. If furosemide is tried, naturally, if it is given for a long time, we'll have to look for the ototoxicity of furosemide. Apart from the diuretics, beta-histine definitely has a role in Meniere's, but then the dose of 24 milligrams twice a day or 48 milligrams once a day is a very good dose that controls and prevents the severity of the attacks, and the prolongation of the interval between the two attacks is also significantly reduced. But then the dose has to be in this dose, like 24 twice a day or 48 at least once a day. Anything below this will work as a placebo, but then maybe, like, there are patients who are still benefiting with that. The third drug which can be used in prophylaxis or active therapy is cinnarizine. Yes, there are patients who need this drug to be given, but then we have to be cautious about cinnarizine, because if there are events when we have prescribed this drug and the patient feels all right, maybe 2 months down the line, 3 months down the line, he will just go to the pharmacist and ask him, I don't want to go to the doctor because I'm benefiting with this. And the pharmacist will be like, he wants to be helpful, so he'll just give away all the medicines. It has been seen, if cinnarizine is being taken for a long time, the patient may have Parkinson's-like symptoms. This works in some patients, like reducing the salt intake. There is no equivocal statement about this, but then we have to take care of the mental stress and tension in cases of Meniere's, because it is also a form of chronic disease. So patients keep on believing why this is happening to me and how I'm going to get rid of this. Avoid coffee, alcohol, smoking, tobacco. Well, increase banana and oranges is because we want some potassium. If we are giving potassium, diamox. This is something which is really helpful, and I trust Professor Mohan Kameshwaran sir has already made it adequately clear to all of us how this helps. The incidence of patients being advised surgery nowadays is reduced because of intratympanic steroids and intratympanic gentamicin. Almost 1/3 of cases of Meniere's have an immunological cause to be suspected. So intratympanic dexamethasone really works well, and given once a week for 3 weeks, we can easily observe how the symptoms have gone down. Intratympanic gentamicin is a better drug for control of vertigo. And it was believed that gentamicin will always give you some amount of hearing deficit. But then we have seen over the years, there have been meta-analysis, many studies which have proven and given us an idea, if we are following the low dose regimen, the hearing really doesn't go down as much as it is expected. Intratympanic gentamicin is the treatment of choice for patients who have drop attacks as a result of end-stage Meniere's, that is called as Tumarkin's autolytic crisis. This is a reference of late. Now you can see the page of this intratympanic transtympanic gentamicin treatment for Meniere's paper by Timothy Hain. The page was modified just 7 days ago and has got the latest information. This is how we saw how intratympanic gentamicin can be given. It's a fairly simple procedure. This is the meta-analysis where you can see if there is a fixed low dose regimen, we expect less control of tinnitus and less control of oral fullness. But then the control of vertigo is substantially good, and the hearing also doesn't go down. But then if you have a very high dose regimen, then you can expect a control of tinnitus, which is better, oral fullness is also better, and the vertigo control is almost 93 to 100%, and the hearing gets worse, but then it goes from maybe in some studies from 0 to almost 30%. Intratympanic steroids versus gentamicin. There is no significant difference between gentamicin and methylprednisolone at controlling vertigo. The overall reduction in vertigo attacks in the final 6 months of follow-up compared with the 6 months before treatment was almost 90% for steroids injection and 87% for gentamicin, which was far higher than expected. Cochrane database of systematic reviews concludes low-dose intratympanic gentamicin proved to be effective and safe for patients. Vertigo control is excellent, almost 84%, and hearing deterioration is hardly 5 to 5.4%. So we had Professor Mohan Kameshwaran giving us an idea. The need of this surgery has gone down to hardly below 5%. Endolymphatic sac surgery, the shunts, the vestibular neurectomies, and the labyrinthectomies. We had an excellent presentation by my dear friend Dr. Avinash on BPPV. Yes, he gave us an idea about how to take care of all these patients of BPPV. Medical management really doesn't have any role. We do see patients who are on medical management in spite of the fact that they have BPPV, and then they have been taking all these drugs for months and years together with no relief. I had a medical practitioner with me who was traveling. She loved traveling all over India, out of the world, everywhere. But then every time she used to travel, she used to pop so many pills, and then she used to carry a cervical collar to prevent any episodes of vertigo and all these things. But then when she came to me and we did a Eplase maneuver, she had a post-canal BPPV. Later on, she tells me for the last so many years, she has not had any episode. So careful history, clinical examination, investigation with video Frenzels, V-hits, we get a correct diagnosis, perfect repositioning maneuver will give instant relief. There will be a few patients who will experience some amount of dizziness, and then it is advocated by some people to give a pill or two of a vestibular sedative to take care of the post-maneuver dizziness. There have been a number of patients who have been found with vitamin D deficiency, and they are to be given 60,000 international units once a week for 8 weeks to help get them rid of all this BPPV dizziness. It's a very difficult diagnosis to make of vestibular paroxysmia, but you happen to make it. Carbamazepine 100 milligrams 3 times a day would help these patients. Other drugs which can help are oxcarbazepine, gabapentin, pregabalin, and then we hear about lacosamide, but I do not have any experience with this drug. Vestibular neuritis was excellently dealt with Dr. Vishal. If the patient presents naturally, the patient will present like an acute vestibular syndrome. We need to take care of the vomiting, we need to take care of the vertigo, and then we have the drugs which we have already mentioned, prochlorperazine, diamenhydrinate, can be given in injectable form. Steroids have a big role to play. Prednisolone has the mainstay. If you diagnose the person in the first 5 days, this will definitely help. 10 milligrams per kg body weight on day 1, 10 milligrams reduced per day and tapered up to 10 milligrams per day, and 10 milligrams per day continued for next 5 days will definitely help the patient have a better outcome after the episode has subsided. Antiviral drugs, there is yes and no, but then nowadays nobody prefers giving this because the studies, double-blind studies which have been done over in the past, where acyclovir was given with steroids, acyclovir was given alone, and steroids were given alone, the results were like the same. So acyclovir really doesn't need, it's not to be given. If we diagnose a case with epileptic vertigo, carbamazepine would be the drug of choice. Along with that, we have many other anticonvulsant drugs which can manage these patients. We had a fantastic lecture today. And then persistent perceptual postural dizziness is one diagnosis we all should keep in mind. Vestibular rehabilitation is the mainstay of treatment in these patients. Cognitive behavioral therapy has been dealt with in details. Physiotherapy, virtual reality really helps these patients. When it comes to pharmacotherapy in such patients of triple PD, escitalopram, that is the SSRI, along with venlafaxine, desvenlafaxine are helpful. We generally start with low dose of escitalopram and it benefits a lot. There is a case for tricyclic antidepressant like amitriptyline, which can also be tried. Bilateral vestibulopathy was dealt yesterday, and the mainstay of treatment would be vestibular rehabilitation therapy. This is something we as clinicians come across, and the history which we typically get from our relatives, our clinician friends, our doctors, our relatives is, अरे ये तो हमारे खानदान में चलते आ रहा है, हमको सबको होता है. And this is something which we need to be addressed, which we need to be taken care of, because it gives some real unpleasant sensation to people who suffer from motion sickness. It's a common physiological response to real and virtual motion. It is caused by sensory conflicts. Of the studies which I have gone through and have seen, most of them tend to agree on the theory of sensory conflicts. The sensory conflicts can be twofold. Either the signals which are sent from eyes to the vestibular system or the semicircular canals to the otolith organs. Motion sickness is common in the young age group between 6 and 12 and in women. Visual vestibular habituation training is the most effective non-pharmacological way of preventing these episodes. This visual vestibular habituation training is a part of army training, and they want all the recruits completely habituated, and they should never suffer from motion sickness. Yoga and pranayama has a great role in treating motion sickness. What are the drugs that can help people who have motion sickness? Yes, we have drugs like dimenhydrinate again, along with cinnarizine, prochlorperazine, meclizine. These are the recommended drugs to prevent motion sickness. They generally need to be given at least 1 hour before the travel starts. The drawback with these drugs is the sedation part. So naturally, after the travel, these patients tend to have a sedation after having consumed all these drugs. Meclizine is a good drug. Why it is good? Because it can be given safely in pregnancy and lactation. Let's see what is the scenario today. Anti-vertigo drugs given for months and years together to suppress vertigo is a common happening today. Off and on, we see patients who have got thick files coming to us. We have got so many prescriptions in them. They keep on changing doctors to doctors. Most of the clinicians, because of probably not having known what is happening latest in the vestibular scenario, prefer to prescribe 1, 2, and 3 drugs, maybe for 7 days, then for 15 days. Some people would not like to see the patient for the next 2 months. So that is the scene which is commonly seen these days. Friends, most of these drugs are CNS depressants. They depress the activity of the brain, and that results in inadequate compensation. I thank Dr. Henry for making aware all the delegates, all the panelists about a beautiful presentation on compensation. The result with these drugs is an uncompensated patient with persistent instability, which is extremely difficult to treat. We have seen patients who have been on anti-vertigo drugs for years together, and these patients are suffering from instability because of the drugs and not because of the preliminary problem they had in the vestibule. It is sometimes even impossible to restore and normalize balance function in these uncompensated patients. Sometimes we have patients, we keep on telling them, Baba, you stop this drug, I'll give you some other drug. No, 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 no. If you stop this, I'll again have problems. So they keep on continuing with the drugs which they have. These are pearls of wisdom from Professor Milind Kirtane. Peripheral vestibulopathies most often leave behind a residual vestibular damage because neuronal cells, they don't have the capacity to regenerate. In acute stage, when a patient has severe symptoms, anti-vertigo drugs are of definite value, but then they are to be given momentarily. However, over a period of time, compensatory mechanisms in the central nervous system, because of the neuroplasticity, allows the patient to come back to a relatively stable equilibrium, which should be the need of the patient, which should be the need of the art. This is something which we want in every patient of vestibulopathy. As a matter of fact, prolonged use of anti-vertigo drugs is likely to hamper these compensatory mechanisms of CNS. The mainstay for treatment of patients of residual vestibular damage is adaptation exercises. We were clearly given a glimpse by Dr. Henry about the various exercises. These exercises are to be customized. The way the exercises are explained today is we have some. I need your consent on a few items to continue. We see patients being given a leaflet which are given by the pharma companies, and we ask them to just follow this. Nobody is bothered about telling them how to go ahead with the exercises. Investigations. We heard these golden words from Professor Anirban Biswas on day one. There is no blanket therapy. We have different types of medicines and therapies for different types of illnesses, depending upon the nature of pathology. Unfortunately, the common trend to treat a patient of vertigo by so-called anti-vertigo drugs is like treating typhoid fever with paracetamol. Science and scientists have established some truths. Drugs that depress the CNS jeopardize the central compensatory mechanism and they inhibit compensation. Peripheral vestibular disorders are usually self-limiting. Vertigo and imbalance is just a symptom or manifestation of an underlying disorder. The causative pathology needs to be known for the treatment. Symptomatic treatment with anti-vertigo drugs may relieve symptoms, but never offer cure to the causative disorder. Objectives of management is to correct the cause, not merely suppress the symptom, and to promote vestibular compensation. Vertigo imbalance and psychogenic disorders are comorbid conditions, and we all clinicians need to keep this in mind and address this issue with sympathetic approach. So a question to all my delegates who are attending this webinar today. Last 3 days, you have seen all the conditions which are presenting with vertigo as a symptom. We have seen the specific treatments for all these conditions. Now, I need to ask you one question. If you or your relatives or your patient is suffering from a vestibulopathy, would you prefer giving 1 plus 2 plus 3 plus 4 drugs and then see that the patient is without vertigo, or you would like the patient to be compensated and rehabilitated, or you want the patient to be cured with proper investigations and treatment? We began with saying which is the way out, but I believe the way in for management of vertigo is proper history taking, meticulous clinical examination, judicious investigations interpreted in the light of history and clinical examination, definitive diagnosis, essential targeted drug therapy, reassurance, and vestibular rehabilitation. I thank you all for a patient listening. I thank the organizers again for having me on this dais. Thank you very much.
A very big thank you, sir. Very big thank you. This was the talk that was needed to end this 3 days program. It was just summarizing the whole 3 days, sir. Thank you very much. Dr. Srinivas, quick comment.
Yeah, see, yesterday Dr. Kshitij had made a point about Charuha sir, that the grand finale is going to be day 3, and the grand finale is the day 3 is the last talk by Dr. Charuhas. So he not just covered the pharmacotherapy, but then after having elegantly covered pharmacotherapy, he made sure that we don't over enthusiastically take up too much. So he made the point that to place it in proper perspective, and almost every drug was covered. Okay, Mohan Kameshwaran sir covered every surgery from his own personal experience, and here Charuha sir covered every drug. And the other main important points that he was telling is, he is talking from his own experience, and from that he is telling about the advantage of medicine, the control, advantage of meditation in the control of vertiginous disorders. He stressed that multiple times, including yoga, those things. So so these are very, very important take home points. Very nice tips each and every place. In some places he used to tell, this is meclizine, the preferred, because it is safe in pregnancy and lactation. So much of clinically usable points. Before that, Dr. Guge, thank you for being so compassionate to share the knowledge among all the ENT colleagues about all the gait abnormalities and a visual memory, so that uh, uh, we can actually start making diagnosis of gait and gait related abnormalities in a much easy manner. I personally feel that from tomorrow onwards, the way I see patients with gait abnormalities is going to be totally different and empowered. Thank you so much for that. And you had a very nice structure of presentation. You presented the basics first, and after that you are relating that to that, so we could make out. Okay, in the beginning you told heel, toe off, every step. I mean, all phases of the gait. Then you used to tell, in here that is not happening. Now the toe is touching, so we could actually relate. Of course, we'll have to again see your video 2 to 3 times, so that everything is committed to memory. And then Henry, what a talk it was. Dr. Henry, okay, it was like how a guided tour of vestibular rehabilitation, just like how you took me to the Megalayan, all the waterfalls and the caves and everything that I walked with you. Okay, in fact, look, going into one of the caves, we got a new concept about BPPV. Probably we'll think of publishing that. And very nice, good structure, in the sense you first told all the molecular basis, neural basis of everything, and then following that you went into the details of exercise. I was only going on taking screenshots, but still I would want your presentation again. Okay, so thank you for that talk. I think may I request Dr. Mohan Kameshwaran sir for his comments.
Basically, I think you covered mostly Srinivas, but I really loved Chara's talk. It's not surprising. I mean, I've heard him many times, and each time it's of the class is a start.
Yes,
I think the important message which he gave was that you have to have a very holistic approach to managing vertigo.
Yes.
I think that's the very, very important take-home point. I would say it's probably the single most important take-home point from this whole 3 days seminar, because there's no single management for vertigo, and you have to be extremely individualistic. You have not only look at the diagnosis, but also look at the patient, and then work out the management. And as he said, long term, your idea is to work with the body, not against the body, and work with the body to help the body to compensate. That's the whole concept. I mean, everything that we do is aimed towards that. So this is the take-home point. Nature is the best physician. Nature heals, and all we have to do is to assist nature.
Yes.
And in the case of the vestibular system, there's a very robust mechanism of compensation, and the neural plasticity is maintained for many years. Unlike the auditory system, vestibular system is much more robust, so you can have neural plasticity going even in the 70s and 80s. And all that you have to do is to help the neuroplasticity to do that, the patient is going to be fine. So that's, I think, the take-home point. So medicine, surgery, all that have the role, but role is quite limited. So at the end of the day, it's the compensation that's the key to management. That's a very good point to take home. Thank you.
Thank you, sir.
Thank you, sir. So I think without much ado, we'll straight away go to the discussions, and I'll be giving out the questions first. So the first question is from Dr. Isha Tuli. She is asking this question to Commissioner sir. Sir, she wants to know, is it preferable to do a canal wall up or a canal wall down procedure for labyrinthine fistula with COM?
Well, I think it's up to you. It depends really on the pathology. I'm not a man who is rigidly for or against any one of them. And you really have to be looking at the patient and the extent of the disease. For example, if you have a very extensive cholesteatoma, most of our patients who present to us in our country have already, very extensive cholesteatoma. It's eroded a bit of the canal wall, has gone here, gone there, everywhere. So you then have to go in and complete the formality of the canal wall. But you don't have to remove the canal wall only to close the fistula. The canal wall is, if at all removed, it is for removal of the disease, not for the closure of the fistula. Closure of the fistula can easily be done with the canal wall up as well. So I think the answer is, it's not the fistula which is going to decide whether the canal wall is up or down.
Thank you, sir. So the next question is again directed at you, sir. If tinnitus persists, what can be prescribed in such cases? I think they mean the cases that you're describing.
If tinnitus is the main complaint, let's say in a patient with vertigo, the chances are that he's got a significant hearing loss along with he or she. And all that you have to do is to correct the hearing loss. So this could mean either fitting a hearing aid if the patient has got residual hearing, or if there is a complete auditory deprivation, then you might go in for a cochlear. So, for example, a Meniere's disease patient who's got severe tinnitus and vertigo and has got a profound hearing loss, it's not an uncommon combination. Then what we do is to do a labyrinthectomy combined with the cochlear implant. We do not combine with a vestibular nerve section in these patients because of the small but significant risk that when we are doing a vestibular nerve section, we could also cause concussion of the cochlear nerve. The cochlear nerve, unlike the facial nerve, is an extremely finicky nerve. You just have to go and touch it, and you could cause a concussion, cause the nerve to be paralyzed. So you try and avoid the nerve as much as you can. So therefore, if you're going to be combining a labyrinthectomy with the cochlear implant, that's a good combination. You can do that. We've done quite a few. I think we have almost more than 40, 45 patients who have had such combination. They do very well. So in one go, you've given them hearing and you also sorted out the vertigo issue. But you don't combine with the vestibular nerve. That helps the tinnitus.
Thank you, sir. Again, this question by Dr. Pooja Suyal. Indication for trans labyrinthine acoustic neuroma surgery and its benefits.
Trans-lab vestibular schwannoma surgery is probably the best approach for a vestibular schwannoma. And the reason is it's the most direct approach. You have the most direct approach to that. Unfortunately, neurosurgical training in our country, it does not include a translabyrinthine. Most neurosurgeons are trained to go retrosigmoid. I mean, I have no quarrel with them. It's pretty okay. You can do that. End of the day, every surgeon must take the approach that he or she is comfortable with. But I think part of the problem is that not the retrosigmoid approach is chosen not because it's a better approach, but because it's the only approach that neurosurgeons are trained in. So it's my usual plea to neurosurgeons is also get trained in translabyrinthine because it's a much more direct approach. And most of the tumors which present to us up to about 40-45 millimeters even can be removed very comfortably with translabyrinthine approach, because many neurosurgeons have this concept that translab is only for a small tumor. It's not. So even up to about, in fact, the last tumor that we did in our center with the neurosurgeons was almost about 42 millimeters. So you can easily do it. And the advantage of a translabyrinthine approach is that the first thing you do is identify the facial nerve. So, you are identifying the facial nerve and then removing the tumor from the facial nerve without damaging the facial nerve. Retrosigmoid approach, the last thing you see is the facial nerve. So that's the difference, the big difference. So for preservation of the facial nerve, the translab approach or translabyrinthine approach is a far, far better approach tumor removal, preservation of facial.
So there's another question for you, sir. This is from Dr. A.P. Shah from Patna. Who are the most ideal case for vestibular neurectomy?
The ideal case for vestibular neurectomy is a case where you have persistent vertigo not managed medically despite maximal medical management. And patient has got significant residual hearing, which is worth preserving. In such a patient, you want to do a selective vestibular nerve segment without damaging the cochlear nerve or you don't want to destroy the labyrinth, so that you want to preserve the hearing. Those are the patients in whom you do a vestibular nerve segment. So in other words, somebody who's got vertigo which is not managed medically despite every effort you've taken, and at least a year's management. And the second thing is that this patient got very good hearing. You don't want to destroy the labyrinth or damage the body.
Thank you, sir. The next question is from Anshu Singh. I think this is directed at Dr. Hajarika. Causes of vertigo precipitated by visual stimuli, as patients complaining blinking lights in bar makes him dizzy, or headlights blinking makes him dizzy. Could it be triple PD?
Okay. See, for triple PD, it is stated very clearly that all the 5 diagnostic criteria has to be taken into consideration. Just a single criteria of blinking lights is not a criteria for diagnosis of triple PD. This could be a case of vestibular migraine also, having headache and giddiness when he sees blinking lights in a bar. So for triple PD, it is very, very important for all the 5 diagnostic criteria to be fulfilled to be labeled as triple PD.
Thank you. The next question is from Imphal, Dr. Supriya Singham. She wants to know, is vestibular rehabilitation therapy indicated in functional dizziness? So Team Shillong can take it. VRT is also there and functional dizziness is also there. Henry and you.
Okay. Yes, I will go first. Yes, it is indicated. Vestibular rehabilitation therapy is definitely a part of the treatment for triple PD. It helps the patient to regain a sense of balance, and it will help in allaying the fears of fall, and it definitely helps in the treatment of triple PD.
Dr. Henry, would you like to add anything?
Absolutely, it's what Zulfi had mentioned. So it is indicated in all these functional vertigo, especially now. What is problem here is the problem in the last phase, not the cognitive phase. So you're trying to correct that. So, but in that event, you're incorporating all the different kind of exercises, right from your improvement in reflexes, your improvement of your spine mobilization, your lower limb mobilization. Okay, your balance, your stance. Okay, all these are to be incorporated, and also most important is to incorporate the orientation aspect or the cognitive aspect of balance. So that's like like exercises, like for example, you make a person read a book and walk and read the book. So you incorporate your eyes is involved, your vestibules involved, your other proprioceptive and reflex are involved. You walk up and for example, like another example of exercises, like you fix on a target, you walk to and fro. Okay, so these are all what exercises are involved in these are more of cognitive exercises.
Okay, thank you very much to Team Shillong. We had a Team Delhi yesterday, we have Team Shillong today. Dr. Pooja Suyal, she wants to know, does walking in a narrow space inducing dizziness a part of triple PD, and does this need psychiatric treatment?
Okay, 2 parts to it. Again, like I said, yes, it could be a case of triple PD, but the rest of the 4 criteria has to be fulfilled again in this case. And like I said before, triple PD is definitely not a psychiatric disease, nor a psychosomatic disease. That has to be understood. It is a functional disorder and it has no relation with psychiatric diseases. However, a patient might have coexisting psychiatric diseases along with triple PD.
Thank you. The first question of the day from Dr. S.B. Fukan, I'm pretty sure there will be many more, sir. Is triple PD really psychological or not? You have already answered that. Which SSRI you think is best in triple PD? When will you categorize MDD syndrome? And for how long should the symptom last to be categorized as MDD?
Okay. So the first part is it is not a psychological syndrome. Triple PD is not a psychological syndrome. The most common SSRI that is used nowadays, I think, is escitalopram. My psychiatric colleagues use escitalopram for depression. And I think that will be the most effective SSRI to be used for triple PD. MDDS is diagnosed if you continue having symptoms after having a voyage or a triggering factor for more than 1 month, then it is categorized as MDDS.
The next question is again directed at Mohan sir. This is from Niteshwar Singh from Imphal. What extra needs to be done to prevent CSF leak in labyrinthectomy in intact canal wall? Is there any other method other than ultrasound disc closure to prevent CSF leak in canal wall down method?
It's a very important question. You see, when you have done a labyrinthectomy, particularly if you also combined with an exposure of intraartery meatus, then CSF leak is natural. If you just do a simple labyrinthectomy without exposing intraartery meatus, you won't get a CSF. But if you are going to combine with the internal artery meatus procedure, then you will have a CSF leak. And it's very important to get a watertight seal before you leave the theater. So this usually involves, of course, because the dura can't be approximated. It means that you have to line the dura. Usually fascia lata is a preferred material. Is also reinforced. And a muscle flap is also used for additional augmentation. Our practice is always to use tissue glue in addition to this, and then do the muscle flap on top of it. So you usually have at least a 3-layer closure. And once you've done that, then you always have a watertight seal. You can post-operatively augment with some Diamox, so to reduce the CSF pressure for a week or so, to help in the prevention. Even so, there may be in about, let's for example, in vestibular schwannoma cases, in about 5 to 10% of cases in any large series, we develop CSF fistula. Despite every effort closure, these patients can be managed usually conservatively with lumbar drain and with Diamox. But if despite that they have it, then we may have to reopen it and then do the closure. Majority of them will just settle down with that.
Thank you, sir. This question is from Ishapreet Tuli. I think this is directed at me. Any role of monoclonal antibody in treating vestibular migraine? Definitely yes. I had mentioned that. There are a few drugs that there. The only problem is the cost. Sir, do you like to add anything to that, Mohan sir?
No, I think you're right. You're right. The main thing is you always start off with the cheapest thing, and the most time-tested thing. Sometimes old is gold, so start off with that, and then go for the latest fancy things when all the old things haven't worked.
This is a question which is related to vestibular migraine, but I would love to have Dr. Srinivas's opinion on this. What is the difference between motion sickness and vestibular migraine? This is from Fukan sir.
Okay, so that's actually a very beautiful question. Okay, so how do you differentiate somebody with motion sickness and vestibular migraine? That comes from the question comes from a certain background where motion is a trigger for migraine also, vestibular migraine also. So what do you call as a motion sickness and what do you call as a motion triggered vertiginous migraine? So generally, how do you differentiate is motion triggered vertiginous migraine is something that comes towards the end of the travel or whatever, and then it lasts for a long time after that. Whereas motion sickness is something that is actually happening during the travel, and once you stop the travel, after some time they feel better. Okay, they vomit and then they feel better. Whereas when it comes to vestibular migraine, which is one of the triggers for vestibular migraine being motion, that one is generally after some travel, and then towards the end of the travel it may start, or after you have completed the travel it will start, and then it will go on for a long time. So that is the difference. Hope that satisfactorily answers sir's question.
There's a second part to that question. What do you think is the best treatment for medication to be used for motion sickness?
Okay, so there are multiple. See, Charuha sir elegantly covered a lot of the medications that are used in motion sickness. Okay, so we can use any of them. One of the thing that we need to keep in mind is that the medicines have to be given minimum half an hour before the travel. Then one more drug which is not actually considered as a motion sickness drug, but which is very, very helpful, is flunarizine. 5 mg of flunarizine taken half an hour or 1 hour before your travel has a salutary effect on motion sickness.
I know you.
Can I just add something there? Now,
yes, sir.
Most popular thing now all over the world is scopolamine patches.
Scopolamine patches, yes, sir. Yes, sir.
It's very easily available. You just put it on your skin.
Yes,
and it lasts very well for a few hours. A lot of people who you'll see going around with these patches, like a plaster sitting there, and that's very effective.
True, sir.
So next time we are on the way to Henry and Zulfida's place, we'll need a few scopolamine patches. So the next question is again from Dr. S.B. Fukan. Why is anti-epileptic drugs used in migraine? So it is used in migraine because of the cortical spreading depression theory, and these drugs are have an antagonistic effect and to prevent the migraine attack. So that is what I know. I hope the other panelists will put something more on that.
See, basically, yeah, you're right. So what ultimately is that, okay, as you rightly pointed out, so there is a cortical spreading depression in migraine and cortical spreading excitation in epilepsy. But whatever it is, both of them are considered as channelopathies. Okay, so there is the primary problem is a channelopathy plus circuitopathy. Okay, so there are neural circuits that go wrong. So what happens in migraine is that this goes from region to region, whereas when in epilepsy, it just goes to different areas simultaneously and very fast. In migraine, it progresses very slowly from region to region. But the underlying whatever, the fire is being set in both by a channelopathy. So most of these anti-epileptic drugs are actually drugs aimed at stabilizing some channels, okay, like sodium channel, calcium channel, these kind of things. So because they are meant to work on those, the way the channels work. So because of that, epileptic drugs and anti-migraine drugs will have cross effectiveness. I'm sure Dr. Vijay Guge will want to add something over here. So may we request Dr. Guge?
Yes, sir. Guge, sir. Guge, sir?
Yeah, I think some microphone. Yeah, I think he's
microphone problem. Yeah, he's having some microphone problem. Okay.
So in the meanwhile, what I can do is, by the time the microphone is fixed, I have one question to Mohan Kameshwaran sir. Okay, sir.
Yeah.
Okay, so sir, if I have a patient with the cochlear carotid dehiscence and severely disabled, so are there any surgical options for such kind of patients?
Cochlear carotid dehiscence, yeah.
Yes, sir.
Yeah, you can actually. There are reports. You can. There are reports of interventional radiologists. Going in and putting in coils and things like that. That's
okay,
that's one thing that you might. You can talk to the interventional radiologist whether they can do something about it. Surgically, I don't think there's been any great effort to.
Okay, sir.
But I think this is one possibility that you can explore. You can talk to intervention radiologists, but there are some reports of oils and things which have been put into the.
Yes, sir. Sir, and one more thing is you also covered one patient whom you were saying about one of the audiologists who had combined superior canal and posterior canal. So what was the approach for the posterior canal to jugular dehiscence?
Well, actually, both of them can be approached, by the transmastoid route. So you can expose both the posterior canal and the superior canal. So here, actually, what I did was I approached the posterior canal through the posterior, through the transmastoid route, and did the superior canal through the middle fossa. So I did both together in one sitting. Because middle fossa is very easy route for the superior canal dehiscence. You really do it in 15 minutes straight. So it's one of the easiest things that you can do. And the posterior canal, you can always outline and then do the repair. So both are very easily combined together.
Great, sir. Thank you, sir. Okay.
So we'll go
Dr.
to
Buke? Is Dr. Buke there?
No. Unmute. Can you unmute your?
We have he's unmuted, but he cannot. He's some problem with his microphones.
Okay.
From Impal, Niteshwar. Niteshwar wants to know the role of WEMP and MRI brain in diagnosing vestibular migraine. So I'll first tell what I know of it. First, regarding WEMP. Now, there are two schools of thoughts. One school says that since vestibular migraine is a central origin thing and has nothing to do with the ears, WEMP has no role in it. There's another group which says that because vestibular migraine reduces the response thing, so WEMP can sometimes give a reduced response. But I don't think it has any direct academic research actually saying that WEMP has a big role. Regarding MRI brain, vestibular migraine, again, I don't think MRI is going to give us a lot. I may be wrong. We have, but when is MRI necessary in vestibular migraine is two situations. Number one, when we have the headache, which is not even after being treated as migraine, or vertigo, which has fulfilled all the criteria of being diagnosed as vestibular migraine, but is not being treated by the typical migraine therapy. MRI is needed because there may be something else going on. In the same is with the case of headache. A headache which has fulfilled all the criteria of a definite migraine, but still is not being treated by the normal anti-migraine therapy. These needs MRI. Also, suppose a patient is suffering from vestibular migraine or normal migraine and has on taking anti-migrainous therapy is getting better, but suddenly deteriorates. Suddenly there is a change in the characteristics of the headache or characteristics of the vertigo, then a MRI is immediately necessary. This is what I know of. So if sir can add anything, Mohan sir, you can add anything.
See, you're right. You're right. See, let's look at the authoritative the reference for it. It's the ICHD, the International Classification for Headache Disorders, and they're very clear. So there are certain clear criteria about when you want to do MRI. Number one, if there is any change in character of the headache. So if the patient has had a headache with vertigo, if there's any change in the character from before, the patient will be able to tell you, this time it's much more severe than last time. Definitely you need to have an imaging done. Similarly, anyone who's over the age of 50, who's presenting to you with, with headache and vertigo, you have to do it. And in short, everything that you said is right. That is, a patient, you cannot diagnose a vestibular migraine by MRI. MRI is done more for exclusion of any other disorder which could imitate migraine. And most of those disorders are serious disorders because they involve the brainstem. So you have to be very, very clear that you ruled out anything else. So end of the day, an MRI is not going to diagnose, a WEMP is not going to diagnose, or all that is very simplistic. The hallmark of migraine is there is nothing, that you're going to do to diagnose it. So basically, everything is going to be normal. But it's very important, nevertheless, to exclude other differential diagnoses, and some of them are very, very important.
Thank you, sir. Niteshwar Singh from Manipur, who had asked the previous question, has a direct question for Mohan sir also. How do we select which vestibular nerve, whether superior or inferior vestibular nerve, to be respected more?
You don't select, you cut both. You chop off both nerves. Yeah, superior and inferior. There's nothing to select between the two. The two nerves join together and then become the common vestibular nerve. So all that you are trying to do is to preserve the facial which is behind it and the cochlear which is by the side of it. The vestibular nerve goes. You don't choose between the superior and inferior.
Thank you. This is a question from SB Fukan sir. It is on vestibular migraine, so directed at me, but I do not know the answer to it. So some other from the Mohan sir or Srinivas sir has to answer. Tryptophan is an anti-serotonin used in vestibular migraine. Serotonin or 5-hydroxytryptamine used in the form of triptans. Whether both are of opposite action drugs, what is the rationale?
Srinivas, you want to answer that or?
Please, can you please repeat the question?
Sure, sir. Tryptophan is an anti-serotonin used in vestibular migraine. Serotonin or 5-hydroxytryptamine used in the form is also used in the form of triptans. Whether both are of opposite action drugs, what is the rationale of using this? This is from SB Fukan sir.
First and foremost, I'm making one request. Fukan sir, please don't set questions for NEET. Nobody will answer. Nobody will get the answer. Okay, please spare those boys and girls. Okay, and frankly, I have not thought about this so far. Maybe I'll read up and then let you know tomorrow, sir. Mohan sir.
Yeah, I'm also not very sure. I think, I don't think the antagonistic action. I don't think that's true. But certainly, what he's saying is correct. There's no doubt about it. Both drugs are used. Preferably, I think, the serotonin uptake inhibitors are probably much more in vogue. Triptans are definitely very much in vogue in management of these drugs. So I think they would be probably the number one that you would think about. But I don't know. I mean, maybe Chardas has got a better grasp of it.
Yeah. Because is there and Dr. Vijay Guge is there. If his mic has become unmute.
Guge sir's mic has been unmuted, but he has not been able to.
His mic has got a problem, I guess.
Okay.
Yeah. So Jagtap sir can answer this question, I hope.
I don't think there's. I don't think they're exclusive.
I haven't come across this situation.
No, so
I think we'll have to get back to answer.
Fukan sir has asked a question with no. I think can Fukan sir be brought inside?
Yeah. You just try.
Dr. Bishwajit Gogoi, our technical director, is trying to bring him in. So he will do the work. We'll put him. So till then, we'll go to the next question. This is by Akhil Sharma, sir. This is on vestibular rehabilitation. What is vestibular overcompensation and how to diagnose? The question: can we advise vestibular rehabilitation for a long time? Ideally, how long? And is it helpful in central disorders? Dr. Henry.
Yeah. What is overcompensation? I'm not very sure what, I have not come across the word overcompensation. I don't know it. Srinivas sir, what is this? If we can add up to this.
No, maybe he's talking about that condition where the center has adapted, compensated, and after that the periphery starts recovering. I'm not sure whether he's referring to that. Periphery starts recovering and then there is a new onset of symptoms. So that comes under the category of something called Erholang's nystagmus and Bacterev's phenomenon. Okay, so where there is a return of symptoms and return of nystagmus because of the central compensation. So I don't know whether he's referring to
but that would be decompensation.
Sir?
So that
is
would be
overcompensation. Decompensation is what has compensated goes off. Here, what has compensated is no longer appropriate because the periphery has already recovered. I'm not sure whether he's talking about that. Okay, so if that is the case, then I think it will settle on its own. The center that is so robust, which could take care of a peripheral loss, will recorrect itself on recovery of the peripheral loss. Okay, but I'm not sure whether that is exactly what he wanted to know.
Thank you, sir. And then the next question is that whether it can be advised for a long time. I guess it generally is for a longer time because by the time the compensation takes place, it's generally it takes about 2 to 4 weeks on an average, generally with a good vestibular rehabilitation, or it may take longer depending on how the person cognitive responses are. So it might need to undergo a therapy for a longer time, but most of them would be on a home-based therapy with a review of maybe once in 2 weeks or so. That's what I would do to a few of our patients here who have long-term imbalance. Mainly these kind of like triple PD. So it does take some longer time, as you know, in those who have developed disabilities. For them, rehabilitation do take a longer time. As how much time, it's difficult to say because there's nothing prescribed like this much time you can do. I'm not sure of any specific duration, but I would stop it when I would ask them to reduce or to stop rehabilitation once they have achieved, they can do the normal daily activities uh, more confidently. That is what I would do, what I've done with few of my triple PD patients. How long that is thing, but and it can it be done in central disorders? uh, See, central disorders, first VRT, as I told, the indication mainly is for diagnosed peripheral vestibular lesion. As far as as central lesion are concerned, the neurologists do send physiotherapy to the physiotherapist. But what protocol the neurologists ask the physiotherapist, I am not so well aware of it. But it would be on terms of I would guess if the neurologist sends for any central lesion, it would be to correct the gait and the posture. Mainly that would because they are the main concern of balance. If that answers.
Very well said. I think. Yeah, Dr. Guge is here. Yes,
sir.
Yeah.
Sir, SSRI group of drug are basically selective serotonin receptor uptake inhibitor. So it will increase the serotonin level. Yes. And your triptans are the serotonin receptor agonistic action. So both the way, one drug is increasing serotonin level itself because it is a reuptake inhibitor, SSRI, and another one is serotonin receptor agonistic. So ultimately, you can see the more serotonergic effect in both the drugs. So it is not like they are acting in opposite direction. Although the name suggests serotonin selective serotonin receptor uptake inhibitor, but it will increase the serotonin. That means it is agonistic action basically by increasing the level of the serotonin. And here the drug itself is a serotonin receptor agonistic, triptans.
Okay. So, good.
So I think that is in one go clarity. Full clarity in one go.
Yes, sir.
Yes, sir.
Thank you, Guge sir. Thank you.
Yes, sir.
So the next question is from Dr. Akhil Sharma sir again. How do you treat vestibular basilar insufficiency acute episodes? Is it same as in a peripheral lesion? So treatment, Charu sir, would you like to answer that?
Dr. Surajit, can you please repeat the question?
The question is, how do you treat vestibular basilar insufficiency acute episode? Is it same as in any other peripheral lesion?
Acute vestibular insufficiency, I think Dr. Guge is the right person to answer the question.
Yes, sir.
Yeah.
Hello.
Yes, sir.
Basically, we have to first elicit the good history and we have to investigate the etiology of the vertebrobasilar insufficiency. If there is a basilar artery stenosis, and if you find on MR angiography whether there is a basilar artery stenosis, then you can go ahead with the antiplatelet drugs along with the high dose of statins, so that whatever plaque is there or whatever thing which is causing basilar stenosis, that means your cholesterol plaque, and that the plaque stabilization is occur with your statins and antiplatelet to prevent further episode like a stroke. You can call it as a posterior circulation TIA like thing, but the question is that whether we should treat it as like a peripheral. So it is not like a peripheral vertigo. We should prescribe the anti-vertigo medications. We have to evaluate the patient, and according to etiology, we have to treat.
Thank you, Guge sir. Any other comments from any of the panelists? Srinivas sir, you're muted. Srinivas sir, you're muted.
Okay. I would like to again seek some clarity from Dr. Vijay Guge. Like, if there is a patient who comes to me and then I'm probably suspecting it is a if the vertigo is because of a ongoing TIA of the posterior circulation. So at that time, even before going for a routine evaluation and all those things, can I immediately start one aspirin and one statin simultaneously, or should I wait for radiological evaluation?
Sir, basically, if patient's event is absolutely patient become absolutely normal after the initial event, whatever event he described, and if he is clinically absolutely normal, then you can simply or safely say there is no bleed.
Okay. Yes,
if
sir.
bleed is there, then there should be some clinical symptoms which should be persistent. If there is no clinical sign and symptoms, you can give aspirin immediately to prevent the further episode, and that should be plain aspirin. And if you want to give ecosprin, which is enterically coated tablet, it has to be crushed and then you have to give. Otherwise, you have to give disprin.
Okay. So
that will act immediately. Yes, sir.
So that's a nice point. So one thing is, when the episode is ongoing, then it is not advisable to give aspirin because it could be okay, wonderful.
First of all, I'd like to welcome S.V. Fukan sir. He is with us now.
Yes,
so, sir, Dr. Guge had given the answer to your question. Dr. Guge, if you can repeat the answer regarding the accessorized agonistic thing to Fukan sir.
Sir, triptans are serotonin receptor agonist. So there is agonistic action. That means more serotonergic action with triptans. And SSRI, that is selective serotonin reuptake inhibitor. That means there is no reuptake. That will increase the serotonin level. By increasing serotonin level, it will act more on the receptor. So it is also serotonergic action. It is not like both drugs are acting in opposite direction. Both are mechanism is different, but in both the drugs there is a more serotonergic action. Hope I am clear. Hello.
Fukan sir, I think you're muted. Please have a look. We're not hearing your sound. No, sir, we are not hearing.
Sound is not coming.
Yeah.
True, you can go ahead.
Okay. The next question is for Jagtap sir. This is from Dr. Hiralal. Is there a role of intratympanic streptomycin injection in vertigo patient?
No. There are no trials. Nobody has used it over the years. And we have a very safe drug in gentamicin because it has got a super selective action. So there's no reason why we should try streptomycin. Streptomycin would be more toxic than gentamicin.
Yeah, the streptomycin is much more autotoxic.
Yeah.
In addition to vestibular toxic, it's much more autotoxic.
Yeah.
So you will have a much higher prevalence of hearing loss in streptomycin than gentamicin. So which is why gentamicin is preferred over streptomycin.
Yeah.
Streptomycin is a big no-no as far as the yield is concerned. This is a question from Sona Mohandas. Does beta-histine have a role in treatment of vertigo other than in menials in the acute stage?
No, beta-histine has no role in management of vertigo, any acute vertigo, including menials. Beta-histine is a drug for chronic vertigo, as chronic menials, not in acute vertigo of any cause. So you are thinking about drugs which act immediately, like prochlorperazine or meclizine and so on. So you are looking at drugs which have immediate vestibular suppressive effect. And you're not looking at a drug like beta-histamine.
The next question again from Dr. Sona Mohandas, again on beta-histamine. Does beta-histamine interfere with vestibular compensation?
Well, if they claim it doesn't interfere, so all these, mind you, you have to take all these claims with a pinch of salt, because the evidence is still not there very much. Now, compared to many other drugs, probably beta-histamine has got less of a vestibular suppressive effect, and that's probably true. But that having been said, is there any rock-hard evidence for either one of them? No, the answer is not there. It's much more by clinical experience that people talk about all that. So I think you have to be a little wary of all these things. Purely scientific base, you have to be a little cautious. But certainly, beta-histamine is not a drug for acute vertigo. That's for sure.
Thank you, sir. There's a comment from Akhil Sharma, sir. He had previously asked a question on vestibular overcompensation. He now explanation given by Srinivas sir is what he was looking for, and he thanks you for that, sir. So this is
Thank you, sir. Thank you.
This is a question from Dr. Smriti Rupa Datta from Silchar Medical College. Mohan sir will remember her. You were there in the Silchar conference. So Smriti wants to know, it was she first comments, it was a wonderful masterclass on vertigo these 3 days. So she wants clarification on a few things. Number one, are the terms vestibular migraine, migraine associated vertigo, and migraine anxiety related dizziness similar? So Srinivas, you want to answer that, sir?
That is straight question for you.
So I want to know from you, because vestibular migraine and migraine associated vertigo are similar, but there is a little difference with migraine anxiety related dizziness.
Exactly. That's a different condition. Yeah.
The second thing is, can we clinically diagnose vestibular paroxysmia without any investigations?
Yes. In fact, what has happened is, I have one patient in whom we could not demonstrate a loop, but clinically it was very much of paroxysmia, and he responded to carbimazepine. And the other thing is, there are a lot of patients who undergo MRI for other reasons, and we do demonstrate cross compression. So generally, we think that cross compression is needed for diagnosis, but rather we should go by of course, MRI we should be doing. In addition to that, we should go by the classical clinical history. Okay, that is one thing. That is a disabling positional vertigo. That is one thing. Then two, we also see that in these patients we can demonstrate hyperventilation induced nystagmus. Okay, more so if you are using some tool to record the eye movement like a video nystagmography. Then one more thing that we can see in these patients is that we can also demonstrate some abnormalities on brainstem evoked, BERA. Okay, so in BERA also some abnormalities can be demonstrated in these patients. So there are a lot of other things. Generally, the moment where vestibular paroxysmia comes to our mind, we only think in terms of MRI. But in addition to MRI, there are other two tools. One is hyperventilation, another is BERA. In addition to that, according to Thomas Brandt, the diagnosis is not complete till you have got a therapeutic trial. You have given a therapeutic trial of carbimazepine and found a response for carbimazepine.
So I just want to add something. Basically, I'm very skeptical about this vascular loop theory. I'm very honest with you.
Yes.
There are many reasons for it. The reasons are that, as Srinivas said, you will see a number of patients in whom you see vascular loops which are completely silent, completely asymptomatic. That's number one. And number two, unlike in hemifacial spasm or in trigeminal neuralgia, where there are very well documented vascular loops where you can actually go. I mean, we have a big series of hemifacial spasm where we go endoscopically, we separate the loop from the facial nerve, and hemifacial spasm stops. So that's a very definite evidence. We don't have such strong evidence in support of vestibular paroxysmia. And as Srinivas said, the very fact that the therapeutic trials, carbamazepine is a drug which works like wonders in this condition. That itself, in my opinion, is against the vascular theory phenomenon. Because carbamazepine doesn't work in hemifacial spasm. It doesn't work like that. So there is something else going on. There's some kind of a neurological disturbance going on at that level, which is not always due to vascular loop. And we have done situations where we've got additional kind of vestibular paroxysmia. We've gone in with vascular loop and separated it, and patient feels good. But I don't think that's an evidence for the condition being proven by that. So I think the jury is still out there regarding the etiology of vestibular paroxysmia. And accepting all that we know for now is carbamazepine is a good drug, so we give it. But should we go in and operate on them just based on a vascular loop which you see on an MRI? I am extremely skeptical about it.
I actually had a corollary question, which was, suppose a patient on MRI for a completely different reason shows a vascular loop. Do we go in and try to rectify that just as a preventive? I think you have already answered that.
Not at all. Yes, absolutely not.
So Dr. Smriti has a third doubt. Is the dose of acyclovir for vestibular neuritis 200 milligram and not 800 milligram? I think yesterday it was mentioned that we do not use antivirals now.
Exactly. That's right.
So it's neither 200, neither...
No, it's 0.
I think, yeah. Even today, Dr. Charuhas sir presented, and there also he told that he mentioned, but then he told the role is not much. Charuhas sir is there?
Yeah. He's shaking his head very much.
There have been 3 trials, but then all of them have conclusively proved that there is no role of acyclovir.
But hello.
Sir is here, sir. Yes.
Can I opine one?
Yes,
actually, antiviral valcyclovir is still used. It is a 500 milligram TDS. Valcyclovir, not acyclovir. Acyclovir is 200 milligram 5 times daily, but valcyclovir twice daily or thrice daily for a vestibular neuritis. They've got references. Another, my point was the pizotifen. Pizotifen was used in vestibular migraine, which is anti-serotonin, unlike SSRI. Then why the counteract triptans and pizotifen is a different molecule? Both action is different, opposite. That question actually I have asked.
That question was answered by Dr. Vijay Guge, where he told.
But he has answered on SSRI. He has answered SSRI, not the pizotifen.
Listen to his, because he was not in at that time.
Yes. Okay.
Yeah. Dr. Guge, if you please repeat about the pizotifen and this thing, sir, please.
No, pizotifen I was never used, but I can talk about SSRI and triptans.
Yeah.
Triptans are 5-HT1 receptor agonist, that means serotonin receptor agonistic action, and SSRI are selective serotonin reuptake inhibitor. So SSRI increases the serotonin level, and triptans are serotonin agonistic action, receptor agonistic. So both the ways there is more serotoninergic action. So 2 drugs are not having action opposite to each other. Pizotifen, sir, I am not aware. I have never used it, but I will search the literature for it.
No, it is written in a presentation that pizotifen anti-serotonin activity. Therefore, I am asking the question.
Yeah.
Okay, thank you.
Sir, Fukan sir,
Mohan sir and Guge sir all.
Fukan sir.
Yeah.
Sir, so your question remains unanswered.
No, it's okay. No problem.
Okay.
Okay, got the answer. Thank you.
So
yes,
that was the last question of the last day of this 3-day seminar.
Yeah.
Before handing over to Dr. Khan for his final comments, I would like to know from the panelists and especially Mohan sir and Srinivas sir about what do you think about the whole 3-day event. Mohan sir, please.
I think it's brilliant. One word to summarize it. I think it's brilliant. I mean, it's so nice to see such clever people all over very difficult topic. And I'm simply astonished at the amount of knowledge it is all around. I've learned so much today as for as I'm concerned. I'm sure most people would have learned something. It's a topic, vertigo is a topic we should never ever cease, because there's so much of unknown commodity there. And we are still learning a lot about the human brain, particularly the vestibular brain. We're just scratching the surface. We still have a long way to go. And what looks like very simple concepts to us, keep changing all the time. It's an amazing discussion. I think today I was simply amazed at the level of discussion. It's a phenomenal event, and my compliments to all the organizers. They've done a tremendous job. All the best. Congratulations.
Srinivas sir.
See, if you have to actually choose which is the best presentation, we cannot choose. That itself means that the amount of effort and that has been put into making these presentations. Everybody has researched so much to bring in that much of knowledge to this 3 days event. So that was the beauty. Actually, 2020, because of COVID, the BalanceCon is not happening, and you have made sure that virtual BalanceCon from Northeast has happened. So that is all how I felt.
Thank you. Thank
Yes.
you. BalanceCon has always been an inspiration.
So,
Dr. Shadua sir wants to say something. Please, sir.
I just wanted to make a comment. Over the years, when we have seen, since last 15 years, I am having a look at patients who have had a problem with vestibulopathies and all this imbalance issues. The number of patients coming with psychiatric overlay or functional overlay appears to have increased over the years. This is the first time I'm seeing a presentation on triple PD. Can we have a correlation or a synergy with a psychiatric department where people will investigate the patients with the overlay, and there will be specific conditions where we need more insight into all these issues so that we can tackle them much better than what we are doing right now?
Correct, sir. Maybe next time we'll bring in somebody from psychiatry for this presentation. This time we had 4 people who were non-ENT background. Next time we'll bring 2 more. Maybe one from psychiatry, one from even ophthalmology. So,
Dr. Surajit.
Yes, sir.
I know it is very late, but one more point that I want to add.
Yes.
As when it comes to awareness, knowledge, okay, these last 3 days have proven that faculty in India are more or less than any faculty anywhere across the globe. So the standard of the lectures were at par. But let us all commit ourselves to one thing. For us to be counted on the international stage, we need to publish.
Yeah.
We need to publish, and we have innumerable number of cases. If we can tonight resolve that by the time next year we do something of this scale, we would have actually had some international publications, original publications coming out of us, not 1-2 case reports, but a series of 10 patients, 15 patients, something like that, theories, hypotheses, all kinds of things. That is going to make us to be taken taken very seriously, because we don't have any dearth of cases, we don't have any lack of any talent. All that we need is, the only thing that is lacking is publication, documentation and publication. I would want Dr. Mohan Kameshwaran sir's views on this.
Yeah, Srinivas, you're absolutely right. Absolutely right. We have the maximum number of patients, maximum number of neurologists, and the minimum number of publications. I think people are totally against this, and it simply boils down to lack of documentation. So I think people have to learn to document their own data and then get into the habit of publishing. All that you have to do is to start up with simple surgical, say simple audits, clinical audits, and from the clinical audits, you start getting very good papers on various things. And believe me, the numbers that we see in our country, in the every clinic, mind-boggling, and yet we don't produce the number of papers we should be doing. I fully agree with you, and I keep on saying this again and again. If you're a very good clinician, you are appreciated in your city. You're a super clinician. You're appreciated in your country. But to be appreciated outside your country, you always have to be a good publisher, be a research which carries you outside the borders of your country. So it's very, very important. And I see there's so much potential, but it's not used.
Thank you, sir.
So before we move on to the final vote of thanks, Dr. Srinivas, you had mentioned about this being at par with international. This was something which has come to my mind for the last, since yesterday. Now this Earth has 7 continents, of which one, Antarctica, is not populated. And in this meeting, this 3-day meeting, we have had delegates from every other continent of this world. We had delegates from Australia. We have had delegates from all over Asia. We have had delegates from Africa. There's delegates from Egypt, South Africa. We have delegates from Europe, Romania, and we had from Spain. We have from Italy. We have delegates from North America, from USA, from South America. We had from Chile, Paraguay, Uruguay. So we have had delegates from all over. This has become a very international event. I'm so very proud of it. And before representative of ABAD delivers the final talk, I would want a final comment from the convener of this meeting, Dr. Gautam Kaunt. So the total delegate count, I'll just let you know, on day 1, total registrations was around almost 1,300, 1,290. Day 2, new registrations was above 700. Today, new registrations and delegates was above 500. So in total, we had around 2,500 delegates in the 3 days. So over to Gautamda, and after that, Dr. Dotana will have the final vote of thanks.
Yes, I thought we would be late, so that's why I thanked everybody in the beginning itself. So I'll just repeat that I wish to thank our mentor faculties, Mohan sir, M.V. Kirtane sir, and Anirban sir for consenting to be here and spending their time with us. Dr. Srinivas for guiding Surajit and the whole team, and all the speakers. I cannot single out anybody because all the papers have been so good, and Dr. Jagtap has put the icing on the cake by summing up everything over the last 3 days. So, and of course, the audience, people who have logged in, stayed for 4 or 5 hours at a stretch in this meeting, and my seniors from the Northeast, Dr. Satyabrata Phukan sir, Dr. A.C. Sharma sir, Dr. S.N. Mukherjee, and Dr. Kudu Samit. They have been so supportive of all the webinars that we have been doing throughout this period. Now I hand over the microphone to Dr. Sen from ABBOT Neurolife. Please, for your front.
Thank you so much, sir. And I'm Dr. Dotana Sen. I head the medical affairs team in ABBOT India, and I represent the ABBOT Neurolife division here. So I know, I'm aware I stand between all of you and dinner, but this entire endeavor would be incomplete without a heartfelt thanks from ABBOT to each and every one of you, the mentor faculty, Professor Kameswaran, Professor Kirtani, and Professor Biswas, Dr. Srinivas, who I have been hearing for the past quite some time now. I mean, the kind of passion, sir, that you demonstrate is truly unparalleled. The convener, Dr. Gautam Khund, academic coordinator, Dr. Surajit Barman, also each and every speaker, and a special thanks to Dr. Chakravarti, Dr. Patel, Dr. Porwal, Dr. Anjana Sharma, Dr. Sandeep Sarma, Dr. Bijlani, Dr. Pawar, Dr. Malik, Dr. Rohiwal, Dr. Hazarika, Dr. Guge, Dr. Henry, Dr. Jagtap, and Mr. Anantu. Thank you each and every one, as well as to the 2,500 delegates who've been with us for the past 3 days. Thank you so much, and have a great Sunday ahead.
Thank you, ABBOT, for your help. Thank you.
Thank you.
Good night, and we'll meet again.
Good night. Yeah.
Srinivas sir, you are muted. Srinivas sir, you're muted. You wanted to say something.
Thank you all. Thank you, sir. Thank you, sir. Gautam sir, thank you. Surajit bhai,
Thank
Viswa.
you, and I repeat again the Indian Academy for being,
Yeah. Thank you. Okay. Mohan sir, thank you, sir. Thank you very much, sir. Thank you, sir.
Thank you, sir.
and
Thank you, sir.
the technical.
Okay. Okay. So I'm ending the meeting.